So, good morning. Let's start the second day of our CardioOncology course. Yesterday, we had excellent lectures and discussions, and today the program is very promising too. And to start, I want to introduce Professor Alexander Lyon. Professor Alexander Lyon is a senior lecturer in cardiology at the Imperial College in London and a consultant cardiologist at the Royal Brompton Hospital, where he is the clinical lead of the CardioOncology service. He is the chair of the United Kingdom CardioOncology Consortium and the president of the British CardioOncology Society. He is also a friend of Portugal and particularly fond of Lisbon. Professor Lyon, thank you for accepting the invitation for this lecture. Let's start. Thank you.
Hello, my name is Dr. Hello, my name is Dr. Alexander Lyon. I'm a consultant cardiologist at the Royal Brompton Hospital in London and at Imperial College, and I'm also the chair-elect of the European Society of Cardiology CardioOncology Council, and I'm delighted to be invited to present a talk today on the baseline cardiovascular risk assessment in cancer patients scheduled to receive cardiotoxic cancer therapy. So as cardiologists, we're now seeing many more patients who have either had cancer previously or currently are treated with cancer who have presented to us with cardiovascular disease. And our oncology colleagues are seeing many of their patients arriving at the oncology or hemato-oncology clinic with pre-existing heart disease, having survived cardiovascular disease in their middle life to then present in later life with cancer. So our worlds are coming together more and more. And actually, there's been very impressive improvements in survival in cancer due to early detection, but also all the modern therapies, and particularly these designer or targeted therapies targeting the particular molecular pathways that are driving cancer. So it's estimated in Europe there are now over 30 million people who have either survived cancer or living with it controlled as a chronic disease. And this number has doubled over the last 3 decades. When you look at the biology of cancer and the biology of heart disease, for example, heart failure, you can see these are diametrically opposite processes. And therefore, if a drug or treatment is developed that's very effective against cancer, it's quite likely it might cause a cardiovascular disease. And that's whether it's interfering with cell division, blood vessel growth, metabolism, and ultimately cell survival, where in the heart we want to improve cell survival under the sort of situations of heart disease, whereas in cancer, of course, they're trying to block cell survival. Back in 2016, the European Society of Cardiology published this position paper on cancer treatments and cardiotoxicity. And you can see that there's all the fields of modern cardiology, the subspecialties are represented because cardiologists will see cancer patients with the complications of their treatment across all the ranges of modern cardiology. We've known for many years that anthracycline chemotherapy such as doxorubicin or epirubicin can cause heart failure, that high doses of radiation to the chest such as mantle radiotherapy to cure Hodgkin's lymphoma can lead to chronic cardiovascular diseases, and the increasing use of fluoropyrimidines such as 5-fluorouracil and capecitabine, its prodrug, can lead to vasospasm and angina, but also heart failure and arrhythmias. We know that if a patient arrives in a heart failure service with advanced heart failure caused by previous cancer therapies. It's a nasty or malignant heart failure to have. Here's a study from colleagues in the heart failure service at Brigham Hospital in Boston, and they looked at patients who were referred for cardiopulmonary exercise testing as part of an assessment for potential transplant or left ventricular assist device. And here on the left, you see the overall survival curve, or Kaplan-Meier survival, and their heart failure was caused by a cancer therapy in the red dotted line. They had a worse prognosis at 6 years compared to all the other causes of heart failure put together after adjustment for age and gender. So this includes post-infarction heart failure from ischemic heart disease, dilated cardiomyopathy from genetics or viruses, and if you include also survival free of transplant, left ventricular assist device, or mortality, again, having advanced heart failure from chemotherapy is a bad thing to have. But of course, we know when these patients are coming to the oncology clinic to receive these treatments. So surely this is an optimal opportunity to consider prevention rather than always responding to the problem. I think it's also important to put chemotherapy in context. If we take doxorubicin chemotherapy, you've got elderly patients who might present with diffuse large B-cell lymphoma or other forms of non-Hodgkin lymphoma, where the cure rates can be very impressive, up to 90% cure rate for diffuse large B-cell lymphoma with R-CHOP chemotherapy. But look here, this is an older population. The incidence of clinical cardio events at 5 years is about 30% of these patients, dominated by heart failure, particularly in the individuals who received the full 6 cycles of treatment and the older. Conversely, you've got younger patients receiving treatment with ABVD chemotherapy for Hodgkin's lymphoma. These are often people who are teenagers or young adults. They're not worried about their 5-year cardiac event rate because they assume they're now cured and back to a normal life expectancy. But this data from the Christie Hospital in Manchester shows that at 18 years of follow-up, when the 20-year-old is now 38, that they had an almost 5-fold high risk of heart failure. Now, we've known for many years that the dose of the anthracycline is the most important factor in determining the risk. And you can see here on the left, as the dose increases, that the rate of clinical heart failure increases. But in the red dotted box are the sort of doses that a breast cancer patient might get, 250, or a lymphoma patient, 300, where again a clinically relevant risk 8 to 16%. But if this is a concentration or dose toxicity curve, you can see lots of factors that can shift it to the left or the right. And this includes a patient's age, pre-existing heart disease, other types of cancer therapies that are also cardiotoxic, such as radiation if the heart's in the radiation field, and potentially genetics. It's a paper that we collaborated in colleagues from both Harvard and Barcelona and studied the incidence of cardiomyopathy causing genes in patients presenting with heart failure or left ventricular impairment after receiving chemotherapy. And if the background incidence of cardiomyopathy causing genetic mutations in a healthy population is around 2 to 2.5%, in this cancer population it was 12%. So it's not everybody, but there's at least an interaction with pre-existing genetic risk. And in the real world, this large study from Daniela Cardinale and colleagues in Milan showed that across 2,625 patients who received chemotherapy with anthracyclines, and these are adults, that if they defined cardiotoxicity as a drop in ejection fraction of more than 10% and to below 50 where treatment was started, that at a 5-year follow-up, the overall incidence was 9%, and that interestingly, 98% of the cases could be detected with surveillance echocardiography within a year of completing treatment. So maybe one practice change is that everybody after completing anthracycline chemotherapy should at least have one assessment, potentially at 12 months, to pick up those who might have developed an early abnormality for which follow-up can be recommended. But the reason I got interested in cardio-oncology is all these new modern targeted therapies that are now curing cancer or controlling it so people can live for many years, but are causing heart problems. And in our cardio-oncology service at the Royal Brompton Hospital, we have patients where one of these drugs was prescribed to them and led to a cardiac problem. And every few months I have to add new names to this list. And we understand the reason for this because if you look at the biology of cancer, and if I show this image to an oncologist, this is a cancer cell. Here are all the pathways that are driving survival and cell division. And in red, at the time the slide was created, are the FDA licensed cancer drugs. But to a cardiology audience, this looks like a heart muscle cell, a cardiomyocyte. And we have 100 billion of these contracting and relaxing in our hearts for every heartbeat. And if we have heart disease, maybe we survived a myocardial infarction or have hypertension leading to left ventricular hypertrophy, these pathways are activated to protect our heart. And the most famous of these is in fact the HER2 pathway. So we know in cancer cells expressing the HER2 receptor, such as HER2 positive breast cancer, it's a aggressive cancer if it has HER2 with increased cell survival proliferation, and this leads to worse outcomes before the HER2 targeted therapies were developed. Whereas in the heart that's injured, the HER2 pathway is activated and it acts as a survival pathway. On the right is a research study performed in a lady who had metastatic HER2 positive breast cancer, where on the top panel, before any treatment, she received a single dose of radio-labeled Herceptin or trastuzumab. And here on the right of this picture, you see her liver metastases from the breast cancer lighting up. And on the left, there's no signal of where her heart is. She then received 6 cycles of doxorubicin and cyclophosphamide chemotherapy. So no Herceptin, just the anthracycline chemotherapy. And then the research study with the radio-labeled trastuzumab infusion was repeated. And now you see her heart light up as the HER2 expression, the molecular white flag, is activated to protect the heart. And we now know if this woman goes on to receive trastuzumab that she has a risk of heart disease and heart failure. And here in this adjuvant trial, so this is women with potentially curable disease getting a 12-month course of Herceptin on top of their anthracycline chemotherapy, the rate of heart problems was 18%. And in the anthracycline alone group, it was 11%. And in this third column, this is trastuzumab plus cyclophosphamide and Taxol chemotherapy, but without the anthracycline, but with the trastuzumab, it was 9%. We also know that if you interrupt the trastuzumab because of heart problems, which has been up till now relatively common practice in surveillance, that there may be an impact. And here in this cohort from New York of almost 550 women with potentially curable early invasive HER2 positive breast cancer, that at 5-year follow-up there were 55 women who had recurrent disease, which is about 10%. And of these, 25% had had an interruption of their trastuzumab during their original treatment, compared to 12.5% in those without recurrence. So the more women who had an interruption of their optimal oncology treatment, the higher the risk of recurrence. And 2/3 of these interruptions were cardiac. If I switch gear to chronic myeloid leukemia, another previously lethal malignancy, now well controlled with chronic drugs such as which are called BCR-ABL tyrosine kinase inhibitors. Imatinib is the first-line drug, has relatively few cardiovascular side effects, but once patients progress on imatinib and need to go on to second or third line drugs, there's a range of problems, including hypertension, heart failure, arrhythmias secondary to QT prolongation, thromboses, accelerated atherosclerosis by a drug called nilotinib, which increases the diabetes risk and LDL cholesterol, and pulmonary hypertension, particularly from a drug called dasatinib. So we know these patients are coming in, they're receiving these treatments, which we know cause potential cardiovascular risks. So what is our strategy? And this is about developing personalized prevention pathways. And last year, this position statement from the CardioOncology study group of the Heart Failure Association of the European Society of Cardiology, in collaboration with the International Cardio-Oncology Society, ICOS, and we took a whole range of experts from all around the world and looked at the evidence of what risk factors predict a patient who's receiving a potentially cardiotoxic drug that they will develop the problem. And as I've mentioned, we can group the potential risk factors into different subgroups. Previous or pre-existing cardiovascular disease being a large high risk. Other medical cardiovascular risk factors such as hypertension, diabetes, lifestyle risk factors such as smoking, obesity and a sedentary lifestyle, raised cardio biomarkers at baseline, so before starting treatment if the BNP is elevated, and if a cancer patient had previous cardiotoxic treatments and now is receiving a new one. So it may be due to recurrent disease with their original cancer recurring, or it could be a new second malignancy, a second primary where more anthracycline chemotherapy is required. And then their baseline heart function on echocardiography and ECG. And we can think of a concept: is the patient purely primary prevention, never had any problems? Are they primary prevention where they have had previous treatment but actually are normal at baseline? And then the patients where it's more a secondary prevention because they've got previous cardiovascular disease or possibly previous cardiotoxicity from a prior treatment. And what we created are these proformas. And if you go to our paper, to the supplement data online, you'll find 7 of these proformas, which you can print out and give to your hematology and oncology colleagues, or if you are hematologists and oncologists listening, you could print these out, download them, and complete them for your patients. And essentially, each of them has a column on the left with the different risk factors. You can then tick if they're present or absent, and each risk factor has a score, which is ultimately a medium or a high or very high risk. And we include in the paper the level of evidence. And then for each patient, you can add up the number of risk factors, and if there are none or a single medium risk factor with a single 1-point scoring, then the patient is considered low risk and they should just continue as normal pathway. If they have medium risk factors that are accumulating risk, totaling a score of 2 to 4, then they might need some closer monitoring. And if there are high risk patients, so anyone with a high risk factor, such as in this example being over the age of 80, or having previous heart failure or cardiovascular disease, such as a previous myocardial infarction, then you should have a cardio-oncology review or cardiology review. And that includes people with lots of the medium risk factors which accumulate. And on the left, you see the different drug classes which we've performed this for. Here's an example of the form for patients with HER2 positive cancers needing trastuzumab or some of the other HER2 targeted drugs. And we did a retrospective analysis of over 900 patients with early HER2 positive breast cancer treated at our partner oncology hospital, the Royal Marsden Hospital in London, over a 7-year period. And you'll see that the overall incidence of cardiovascular toxicity in this real world cohort was 16%. And if you take the low risk patients, it was 14%, medium risk 17%, and in the high and very high risk, it was 30%. So this did detect the high risk patients. And what's interesting is if you divide the low risk cohort into those with zero risk, which actually was only less than 10% of the whole cohort, they actually had a relatively low risk. Whereas as soon as you had one risk factor giving you 1 point, it immediately increased the risk. We also published last year a position statement on cardiovascular imaging in cancer patients. And again, this is from the Heart Failure Association of the ESC in collaboration with the CardioOncology Council and the European Association of Cardiovascular Imaging. And of course, there are lots of different ways we can assess heart function, particularly with echocardiography and modern echocardiography using 3D measurement of left ventricular ejection fraction, which minimizes variability with repeat assessment. Also interested in global longitudinal strain if you have the technology and expertise to measure it reproducibly as an early marker of dysfunction. And we always measure the blood pressure because that can directly influence the ejection fraction, as you know. Also consider measuring the biomarkers and using the imaging together with biomarkers. And if echo cannot measure heart function due to poor windows and imaging accessibility to high quality windows, then cardiac MRI may be an alternative. Lots of debates about the cutoffs for ejection fraction. We practically use 50%, and patients with an ejection fraction between 50 and 54 are higher risk if that's at baseline, and if it declines from a higher level into that range, then they require closer monitoring, whereas below 50 is definitely abnormal. As I said, I think now in a modern cardio-oncology service, we use 3D measurement of ejection fraction and global longitudinal strain on all our patients. We also think there's an important role of cardiac biomarkers, and this is a third position paper, which again I draw to your attention from last year. And this is important when you reflect on pathophysiology. So if we take our patients on the top left receiving anthracycline chemotherapy, then during the treatment, we know cardiac troponins are the most sensitive and important biomarker for detecting early risk. Whereas in survivors who previously had anthracycline chemotherapy, then natriuretic peptides such as BNP become more relevant. Conversely, in patients receiving trastuzumab for HER2-targeted therapies, the natriuretic peptides during treatment that are better at predicting the development of LV impairment, whereas a baseline cardiac troponin, if they've had preceding anthracyclines before starting trastuzumab, is most helpful. And finally, in the patients receiving checkpoint inhibitors, again, both natriuretic peptides and cardiac troponin are helpful. And what we've developed, these personalized surveillance protocols, where if you calculate a patient's baseline risk, you can then determine how frequently they need to be monitored. So if you take a patient who requires 6 cycles of R-CHOP chemotherapy for their lymphoma, if they're low risk, they need the baseline assessment, because you need that to clarify if they are low risk, knowing their baseline ejection fraction and biomarkers, and then the 12-month follow-up, as I mentioned, in everybody. And there's the option for an assessment after 4 cycles if you have any concerns. And this is in an asymptomatic individual. Of course, if they develop cardiac symptoms, then one is guided by those. Conversely, a high-risk patient, maybe someone with borderline LV function, previous myocardial infarction, bypass surgery, now developed lymphoma, they should have potentially assessment every 2 cycles, and at the end of treatment, an earlier assessment at 3 months rather than just waiting for 12 months. And at the Brompton, we studied all our patients and came up with a classification of the patients who develop heart failure in classes 4, 5, and 6, either with heart failure preserved ejection fraction, asymptomatic severe LV systolic dysfunction, or true heart failure with reduced ejection fraction. But also the patients where you're using surveillance and picking up earlier, more milder changes, such as rises in biomarkers with normal imaging, or reductions in global longitudinal strain where the biomarkers are normal, or a combination of both of those, but where ejection fraction remains normal and the patient remains well and free of symptoms. And then we can guide what treatment is required, both oncology, what's your strategy regarding the treatment, which is to continue if these early sensitive tests are picking up change, because remember, these are evidence-based oncology treatments that are proven to improve long-term cancer-free survival and long-term outcomes. Of course, if a patient has symptomatic heart failure, the balance may be to stop or interrupt the treatment, rescue, recover the heart function, and then reassess the risk balance of continuing in a multidisciplinary discussion. And also how we can guide cardiac treatments should the patients start an ACE inhibitor, a beta blocker, or maybe if it's very mild changes, just have closer monitoring to see if a reduction in global longitudinal strain returns to normal or continues to decline. And of course, this generates a lot of information. This can lead to new strategies where we can apply artificial intelligence to pick up who will detect and have problems. And finally, we've traditionally focused on anthracyclines and Herceptin and now all these modern treatments, but we should never forget another old treatment that's been around for several decades, which is androgen deprivation therapy with gonadotrophin receptor agonists. So you probably know of gazellerin, or otherwise known as Zoladex, and Luprolin or Luprolide, and these increase the risk of diabetes, increase LDL cholesterol, and accelerate coronary artery disease in the older patients, men with prostate cancer who have these drugs. So we also recommend doing a cardiovascular risk assessment focused more on vascular risk in men before starting these drugs for prostate cancer. And of course, we're familiar with a variety of these risk scores, such as the ESC heart score and the Q risk score. Finally, patient education is really important, and in the UK we partnered with Macmillan Cancer to produce this patient information leaflet, which is available online, so you can share that with your patients. So in summary, I hope you found this helpful. Cardiotoxicity is a growing problem. It affects old drugs such as the anthracycline chemotherapy and Herceptin, and the new drugs which are targeting these molecular pathways. Most of this is reversible if you pick it up early, and most importantly, we believe it's preventable. And now we have these new performers from the HFA and ICOS for baseline cardiovascular risk assessment, which should be implemented in the oncology clinics and the hemato-oncology clinics to risk stratify the patients before they start these treatments, and then identify high-risk patients who could be referred into a cardiology and in particular a cardio-oncology program. So I hope you found this interesting, and that you can take these performers and implement them in your practice. And key, of course, as a foundation to this is communication between cardiologists and hematologists and oncologists working together to deliver better outcomes for our patients. Thank you for your attention.
Thank you, Professor Lyon, for this excellent lecture. In fact, with so many old and new cancer drugs with potential cardiotoxic effects, personalized approach, of course, makes sense. Thank you. Professor Lyon had to leave because he had an emergency patient, and he cannot be present for the discussion, unfortunately. So I have to ask Dr. Claudia George to take the floor. Thank you very much.
Hello, good morning, everyone. I'm very pleased to be here today at the fourth postgraduate update course in CardioOncology and to be able to present Dr. Miguel Menezes to talk us about management in acute and chronic coronary syndromes in cancer patients. Miguel is an interventional cardiologist that we are very lucky to be in our team in University Hospital of Santa Maria, and is also, of course, a friend, and he has a special interest in cardio-oncology. So, Miguel, can you please talk us and share your experience with the cardio-oncologic patients and coronary syndromes?
Hello, everyone. This talk will be about managing acute and chronic coronary syndromes in cancer patients. Now, as we know, cancer and cardiovascular disease are the two leading causes of that in the developed world, and a large part of cardiac disease is actually coronary. So this is indeed a significant problem. Now, we estimate that these days in Portugal, we would have, based on US estimates, at least 60,000 cancer patient survivors. And when we think about the fact that we generally do about 14 to 15,000 PCIs in Portugal every year, then we start to get a larger picture of how big a problem this might actually be. Now, when we're thinking about coronary artery disease and cancer patients specifically, the first thing we need to think about is how do you assess risk? Is it exactly the same as the non-cancer patient, or is there something different? And I would argue that the patient-related risk is largely similar to the general population. However, there are specific issues in terms of cancer patients that are mostly, in my opinion, therapy-related. Now, the first thing we must bear in mind is that there are many cancer drugs which can be toxic for coronary arteries, be it because of classic coronary syndromes or because of vasospasm or because they may be prothrombotic. And these are actually some of them quite well known. It's the case of 5-FU or the case of platins or the case of angiogenesis inhibitors. But generally speaking, especially cardiologists, we obviously have no true dominion of these drugs. And so generally speaking, I think it's a good idea to keep this table at hand because it's very useful to consult it and update it on a regular basis, which is what I do. So the first thing you need to do is you need to assess the chemotherapy drugs that the patient is doing and whether they are coronary toxic, there's coronary toxicity associated with it or not. In addition to cancer drugs, there's also the issue of radiotherapy. Radiotherapy can be toxic to the coronary arteries. It can have some rather unusual phenotypes like specific osteal lesions like the one you can see here. And it can also have a very late presentation. So this is also something that should be brought to mind when we think about assessing risk. Other than that, the assessment of risk is not particularly different from that of the general population, and classical cardiovascular risk factors still apply. Now, in addition to this, and once coronary artery disease is clearly suspected or known, the second thing we have to think about is where are we with coronary artery disease? Are we talking about a chronic coronary syndrome, which was previously called stable coronary artery disease, or are we talking about acute coronary syndrome, because the implications are quite different. Now, starting with chronic coronary syndromes, considering that in cardiology there's a widespread, long-lasting debate about whether we should go mostly conservative or mostly invasive for chronic coronary syndromes, I would say this. While I do think that we should go mostly invasive for the general population, and this is a personal opinion, I think the opposite when regards to cancer patients. We should probably go mostly conservative in cancer patients. Now, why is that? And that's mostly because of the fact that most of the evidence that we have right now shows that while there can be a benefit to the invasive treatment, and I'm specifically referring to the ischemia trial, the event rates are generally both low and slow. Thus, this means that for cancer patients, it's probably best to leave coronary artery disease alone with medical therapy rather than moving on to invasive, because the benefit is going to be quite slim and the risks are going to be quite considerable, as we see in just a few minutes. There are, however, exceptions to this particular rule. The first exception is there are patients that are severely symptomatic. And the reason for this is because also the ischemia trial, as well as many others, have shown that revascularization can be significantly more effective in terms of relieving angina than can medical therapy, especially when the patient is severely symptomatic or refractory to medical therapy. The other exception is patients with critical anatomy, especially left main, because these patients were left out of the ischemia trial and thus should not be ignored. And the last exception is patients with impaired systolic function, because the Stitches trial has shown us that revascularization can lead to improved survival in these patients, and also because these patients have been ruled out from the ischemia trial. Thus, patients with impaired systolic function should be considered for revascularization, even if they have cancer. Now, when we think about medical therapy, which is the same as saying conservative treatment, what does that mean? Well, it means to use drugs that are going to change prognosis, which are antiplatelet drugs or anticoagulants when there's an indication for that. It means lipid-lowering drugs, it means ACE inhibitors, and it means general cardiovascular risk reduction. In terms of symptom relief, this means the use of beta blockers, unless we think that we're dealing with a vasospastic mechanism. It means calcium channel blockers, it means nitrates, and it means other drugs as well. Now, while for chronic coronary syndromes, I personally find the answer to be relatively simple. In terms of acute coronary syndrome, the general rationale is much more complicated. And the reason for that is because there's very little evidence to guide us in this particular group. Now, I do think that we should probably consider using the same risk scores that we use, and that we should have a very low threshold for performing a coronary angiogram. There's a big difference between looking at the coronary arteries and actually deciding on revascularization. And then whether we do PCI or surgery will largely depend on anatomical characteristics, on patient characteristics, especially considering the vital prognosis and the risk of complications, which is inherently higher for cancer patients, as we'll see in just a few seconds. Now, there are guidelines for these patients. However, they're based mostly on common sense rather than evidence, because evidence is quite slim, but they do have some quite interesting insights. The European position paper, however, is actually very slim on recommendation, is not particularly helpful. It just says that we should probably minimize coronary interventions and minimize dual antiplatelet therapy duration, but it's actually very vague and not based on evidence at all. So what do we have in terms of evidence? Well, one of the biggest papers that has been published so far, which is retrospective in nature, deals with the US Registry on Percutaneous Coronary Intervention, and specifically focuses on the subgroup that had cancer, although most patients had past cancer rather than active cancer. Still, the insights are quite interesting. So what they've seen that there were 4 dominant types of cancer in this registry. Those were prostate cancer, lung cancer, colon cancer, and breast cancer. And interestingly, there are quite curious details. First of all, when we think of cancers as a whole, the cancers are not all the same. In terms of risk of mortality and complications, lung cancer patients fared the worst, whereas breast cancer patients fared better. Now, importantly, it's also very important whether we have a current cancer diagnosis or a past cancer diagnosis. And a current cancer diagnosis is, of course, much more important for cancer types, except in breast cancer patients. In addition to that, we also have situations of whether there are metastases or non-metastases. And again, metastasis is very important, and is very important for all cancer types as well, with a significant increase of both mortality and complications. Now, the same group has also undertook a specific approach with regards to readmissions within 90 days for acute myocardial infarction and bleeding in the USA. And this group is found largely the same with regards to with the same subtypes of cancer patients. So again, lung cancer patients fared the worse, breast cancer patients fared the better, and prostate and colon cancer patients fared somewhere in between, with colon cancer patients facing a little bit worse. Interestingly enough, readmissions were quite frequently in cancer patients, and they were usually quite early, especially mostly due to bleeding. Another interesting paper that was also published not too long ago was ischemia and bleeding. This is another registry, this time mostly from Europe. And what they found is that cancer patients were, of course, at higher risk of death, at higher risk of bleeding, but not so much at higher risk of future myocardial infarction, and very importantly, not at very high risk of stent thrombosis when compared to the general population. Also, this was also very different depending on whether the patient had a past cancer diagnosis or a current cancer diagnosis, because of course, more recent diagnosis was associated with worse prognosis. And so when we try to think about all of these papers and all of this evidence as a whole, I would say that the overall conclusions are that active cancer always carries a worse prognosis. Lung cancer is the worst type of cancer in terms of coronary artery disease and acute coronary syndrome. Breast cancer is the best one with the lowest risk of complications and mortality. Colon and prostate are somewhere in between, with colon faring worse. Cancer patients mostly have an increased risk of bleeding, but not so much of thrombotic complications, including stent thrombosis, and readmissions are higher and often early in patients with cancer. So when we try to put all of this together and whether we should move on to PCI or revascularization or not in patients with cancer, I would argue that factors favoring intervention and revascularization are an ACS presentation, the presence of critical anatomy, not so bad cancers like breast cancer or prostate cancer, localized disease, and past cancer. Factors that don't favor intervention are chronic coronary syndromes, non-critical anatomy, lung cancer, and to a lesser extent colon cancer, and then metastatic as well. Now, when we think about moving on to percutaneous coronary intervention in these patients, there are a number of safety precautions that we should bear in mind. The first lies in platelets and anemia. When we think about simply doing a coronary angiogram, it's generally accepted to perform it in almost any setting unless the patient has very severe anemia or very significant thrombocytopenia, in which case they should be transfused. When we think about moving on to PCI, however, you do need to have a higher threshold for transfusion because you probably shouldn't do it if the platelet count is lower than 50,000, especially if there's descending kinetics. And you should probably consider reducing the heparin dosages, avoiding EP2B3A inhibitors, and eventually, who knows, preferring bilirubin. In terms of access, whether we should go radial or femoral, it seems pretty clear that we should go radial. There is a mounting amount of evidence with regards to this, and the risk of bleeding is much lower in the general population, and consider that bleeding is the single biggest problem in cancer patients, and certainly radial should be the default. If for some reason we should, however, have to go femoral, we should optimize the access, we should use hydrophilic sheets, and we should perform femoral angiography at the beginning and the end. With regards to stent technology, the Americans still argue that we should probably use BMS for these patients. I would argue that considering everything that we know in terms of stent technology, there's a wide amount of evidence that supports the use of DES stents for all patients. This is a clear view in Europe. Even what little evidence we have in cancer patients also favors this approach, and so I would argue that we should always use DES as a default strategy in all patients. And in terms of antiplatelet drugs, I would say that we should probably minimize EP2B3A inhibitors. We should probably avoid ticagrelor and prasugrel and stick with prasugrel. We should also bear in mind some very specific issues, such as the use of paclitaxel, which might actually increase if the patient is taking clopidogrel. We should probably minimize that if there's pressing surgery or bleeding. And remember that if there's active chemotherapy, then delayed stent endothelialization may be present, and thus we may have to prolong that if we absolutely need to, and if the patient can tolerate this. With regards to DAPT duration, well, we know that in terms of acute coronary syndrome, we tend to favor 12 months, and in chronic coronary syndrome, we currently tend to favor 6 months, but this can be reduced to a minimum of 1 month if deemed absolutely essential. In terms of anticoagulant drugs, which is an issue that is mostly relevant in the setting of acute coronary syndrome, we should probably stick to fondaparinux just like we do in the general populations for non-STEMIs. We should avoid the crossover of heparins, and perhaps bivalirudin or a lower dosage of heparin should be preferred as well. So I would finish this talk by saying that regardless of clinical presentation, medical treatment is absolutely paramount in coronary artery disease. And in addition to classical risk factors, specific cancer drugs or past radiotherapy can pose risk. You should probably keep this table at hand, review the cancer drugs, update the table, and think about whether the drugs the patient is currently taking are a specific problem or not in terms of coronary toxicity. You should remember that PCI in cancer patient is possible with limitations. In chronic coronary syndrome, it should be mostly for patients with critical anatomy, severe symptoms, or an abnormal left ventricular ejection fraction. And in acute coronary syndromes, it's one thing to see the coronary arteries, it's another to revascularize patients, and revascularization should be carefully done in selected patients, considering not just the coronary anatomy, but also the cancer characteristics as well. And lastly, if we do move on to stent implantation, procedures should be individualized, minimized, simplified, and technically perfect. Some degree of thrombocytopenia and anemia are acceptable. Radial access should always be the default. Drug-eluting stents should always be the default, and that can be reduced if absolutely necessary to a minimum of 1 month. Thank you.
Thank you, Miguel. That was a very, very good talk about interventional in coronaries and cancer patients. As an interventional cardiologist, although I have some concerns regarding dual antiplatelet therapy and patients with the high bleeding risk. So if really a patient dual antiplatelet therapy with cancer as a bleeding event, what would be your regarding this issue?
Well, it depends on the bleeding event itself. So generally speaking, most bleeding events are not major but minor, and they're reasonably manageable. So my main concern at first would be to make sure that the patient would not stop the APT unnecessarily, so to speak. Of course, that if you have major bleeding, especially life-threatening bleed, then of course you would have to stop, and you probably have to stop them both. The second issue pertains to where the patient's bleeding from as well, because generally bleeds from the GI tract, especially the upper GI tract tends to be particularly violent in nature, and so that would also be a situation where we would probably need to stop as well. And the third point would be where at which stage we are with regards to the APT. So the critical period in terms of stent thrombosis is mostly the first month. If we think about stent thrombosis at 1 year, half those cases happen during the first month. So if we're well beyond 1 month of the APT and the bleed happens then I'm less concerned about stopping the APT. If the bleed happens during the first month, I would try as much as possible to not stop it, if possible. Although this can be quite a challenge, because as we've seen in that paper with regards to recurrences and readmissions, bleeds tend to happen mostly early, often because we didn't know that there was some sort of hemorrhagic substract there that manifested once we started the APT. So that's also a relevant issue to bear in mind. Another possible strategy, especially if we're dealing with chronic coronary syndromes and there's a little bit of time to plan, is it might also be reasonable, and this is a little bit off-label, it might also be reasonable to start the APT a little bit before actually moving on to an invasive stratification, so that if there's a bleed event that can be corrected prior to PCI, it can be it can manifest itself, and we can do something about it before PCI. So that's something that I also sometimes think about in specifically in cancer patients.
Thank you. That was very, very enlightening, and thank you once again for sharing your experience.
So I guess that if there are no further questions, we're going now to move on, and it's now my great pleasure to introduce Dr. Claudio Jorge. Claudio, thank you for coming to our course. Claudio Jorge is an interventional cardiologist at Santa Maria University Hospital. We're also very, very lucky to have her with us, and I'm also very lucky to have her as part of my team. And also as a friend. Dr. Claudia is well versed in pretty much every single procedure that we do at Santa Maria, which is almost everything that can be done in interventional cardiologist. She does both coronary and structural. And while I addressed the coronary, my coronary experience in my presentation, she too has treated cancer patients both in the coronary and cancer. So she's a wonderful person to talk to us about this subject. She's also involved in the BPA program, which is particularly cumbersome and challenging with great success. And so it's my great pleasure to give you the floor to discuss your opinions and experience with structural intervention in cancer patients.
Hello everyone, good morning. I'm delighted to be here today to talk to you about structural transcatheter cardiac interventions in the cardio-oncological population. As we know, modern cancer therapies have resulted in prolonged survival and decreased mortality for many types of cancer. Consequently, cancer patients have concomitant cardiovascular disease that was present prior to the diagnosis of cancer, resulting from various forms of cancer therapy, or developing after cancer remission owing to age and risk factors. These complications include valvular disease, myocardial ischemia, arrhythmias, hypertension, valvular heart disease, thromboembolism, pulmonary hypertension, and pericardial diseases. But definitely, these patients are at a higher risk for development of cardiovascular associated morbidity and mortality. Management of cardiovascular disease, particularly structural heart disease, in this patient population is challenging and associated with elevated or even prohibitive surgical risk. And minimally invasive transcatheter procedures have emerged as lower risk treatment modalities that have shown efficacy and safety. Aortic stenosis is the most common form of valvular heart disease in Western countries, affecting up to 43% of the general population. As it is associated with advanced age, frequently it develops naturally in older cancer survivors. The estimated prevalence of aortic stenosis in patients with concomitant malignancy is estimated to be nearly 30%. Importantly, aortic stenosis is a leading cause of cardiovascular mortality in cancer patients undergoing treatment regardless of the therapy-induced effects. Mediastinal radiation therapy used in the management of a wide range of malignancies such as breast cancer, lung cancer, lymphoma, and metastatic testicular cancer has been shown to accelerate or cause de novo aortic stenosis. Radiation-induced valvular disease is present in up to 60% of patients after mediastinal radiation, but rates of severity vary among studies evaluating different forms of malignancy, and also different risk factors of which it should be highlighted the younger age at the time of exposure, namely incurable malignancies, is particularly important in whom the risk of developing late cardiotoxicity is high. Direct tissue damage by radiation is mediated by the loss of endothelial cells with subsequent inflammatory responses, which ultimately result in valvular fibrosis. Valves become thickened and calcified, resulting in leaflet restriction. This process is also potentiated by radiation-induced osteogenesis in aortic valve interstitial cells. In radiation radiation-associated valvular disease, thickening and calcification are more extensive than in the degenerative disease, frequently involving the valvular annulus, also subvalvular apparatus, or even the aorta. Left side valves are more often involved, and the hallmark of prior mediastinal radiation is thickening and calcification of the aortomitral curtain. And no surgical risk models have integrated this added anatomical complexity in cancer patients. It is also important to recognize that radiation-induced valvular disease has a long latent period, and this means that cancer survivors may only have symptoms 20 years after achieving remission. Aortic or mitral valvular regurgitations are the more commonly seen dysfunctions. Radiation-induced aortic stenosis, mixed forms of stenosis with aortic regurgitation, and mitral stenosis are more frequently reported. But aortic stenosis is typically the main reason motivating surgical options. And once again, it should be highlighted that this group of patients with radiation-induced valvular disease is young, with a significant mortality owed to the valvular disease and with a low rate of cancer recurrences, which poses a challenge in the diagnosis and more in the treatment. Prior to the widespread adoption of TAVI, management of severe aortic stenosis in patients with active or recently diagnosed cancer were more often treated with medical management despite the presence of significant symptoms than with surgery. In a 10-year single-center retrospective study, cancer patients with severe aortic stenosis had a 5-year mortality of 48%. Most deaths were due to cancer progression, but a quarter died with heart failure. However, in less advanced disease, cancer stages, it was non-treated aortic stenosis that significantly reduced mortality. So, aortic stenosis is an independent predictor of increased cardiovascular mortality in patients with cancer, irrespective of whether the cancer is active or not. The uncertainty regarding long-term survival and the high risk of perioperative complications in cancer patients has deterred surgeons from performing aortic valve replacement in the past. But, interestingly, in a small retrospective trial, aortic valve replacement had a better survival compared with the medically treated patients, provided a survival benefit in patients with severe aortic stenosis, irrespective of cancer status or the presence of metastatic disease. Long-term survival was reduced in the active cancer patients submitted to aortic valve replacement because of cancer complications. Cardiopulmonary bypass, yes, as you know, is not contraindicated in cancer patients, but may induce immunosuppression, increase inflammation, and worsen cancer outcomes. Long-term mortality in patients with previous chest radiation therapy was higher than expected after aortic valve replacement and can reach up to 55% at a mean follow-up of almost 8 years. Aortic valve replacement has several technical challenges, including mediastinal fibrosis, recurrent pleural effusions, and poor wound healing. Also, aortomitral curtain thickening calcification is being recognized as the hallmark of previous RT radiation, and its extent is strongly associated with mortality in subjects undergoing cardiac surgery. Importantly, no surgical risk models have integrated all this added complexity of either active cancer or a history of cancer in remission. Since being introduced, transcatheter aortic valve implantation, meaning TAVI, has become the benchmark for percutaneous aortic valve interventions. Although initially emerged as the first choice therapy for patients with severe aortic stenosis who cannot undergo open heart surgery or are at a high surgical risk, TAVI may be an optimal treatment strategy in selected oncological patients with severe aortic stenosis. At least theoretically, TAVI may address many of the concerns associated with open heart surgery in cancer patients, such as increase for bleeding and infections and the suspension of anti-cancer therapy during the post-surgical recovery window, and also overcome the technical difficulties typically associated with aortic valve replacement. In addition, TAVI may allow a more aggressive and optimal cancer treatment soon after the procedure. Real-life recent data shows us that more than 20% of cancer patients with severe aortic stenosis are treated with TAVI. TAVI was associated with lower odds of acute kidney injury and major bleeding, with no difference in in-hospital mortality and stroke compared with aortic valve replacement. In addition, TAVI was associated with higher odds of home discharge compared with aortic valve replacement among patients with cancer. This data is also similar to patients with prior mediastinal radiation. TAVI patients were then compared with aortic valve replacement. These had increased overall frailty and more frequently comorbidities such as older age, chronic lung or kidney disease, prior vascular disease, and coronary artery bypass grafting. Although these baseline comorbidities, TAVI performed better than aortic valve replacement, with reduced needs for mechanical circulatory support and lower risk of respiratory complications and major bleedings, leading to a lower risk of in-hospital mortality, albeit at the cost of increased risk of permanent pacemaker implementation. The difference in outcomes for patients with cancer and active cancer versus those in remission was demonstrated recently in a registry that included 1,800 subjects treated by TAVI. 30-day mortality was the same between the subgroups irrespective of cancer stage, cancer history, or cancer absence. 1 year mortality was highest in patients treated with TAVI who also had active cancers versus those with cancers in remission. But there was no difference in 3-year survival in patients with history of cancer compared to those with no cancer. Although TAVI patients had needed a specific cancer treatment in the first 12 months after the valvular intervention, had a 4-fold increased mortality than patients in true remission. However, long-term data have been variable. The Ocean TAVI registry-based study found no difference in short-term complications or mid-term outcomes between patients undergoing TAVI with or without active cancer. However, the presence of metastases at the time of TAVI was associated with increased mortality. The TOP AS registry was a large registry-based interventional study of 2,500 patients who underwent TAVI, 222 of which had active malignancy. Of note, 40% of patients had stage 4 cancer at the time of TAVI. There were no difference in acute procedural complications or 30-day mortality, but 1 year mortality was higher in the cancer group. Notably, stage 1 and 2 cancer patients had similar outcomes to non-cancer patients, while those in more advanced stage 3 and 4 cancer had significantly decreased survival. A recent single-center study in Germany shows similar results, but for the first time with 10-year survival that was worse in active cancer patients. Current practice guidelines largely reflect this data, but also strongly emphasize that the decision to proceed with surgical aortic valve replacement versus TAVI requires a multidisciplinary ART team evaluation to patient-specific procedural risks, frailty, preferences, and also comorbidities. Importantly, the decision to proceed to TAVI in patients with prohibitive surgical risk is only recommended when the patient's overall post-TAVI prognosis is greater than 12 months, at least in the United States. Unfortunately, in cancer patients, particularly those with a new diagnosis requiring treatment with concomitant severe aortic stenosis, it is difficult to accurately predict long-term survival, making the decision to pursue TAVI in these patients challenging. Also, certain forms of cancer therapies can have significant hemodynamic consequences in patients with severe aortic stenosis, thus requiring more severe aortic stenosis be addressed before any potential life-threatening prolonging treatment or surgery. In the European guidelines, survival timing is not required, although the procedure should not be performed if it is unlikely to improve quality of life or survival. Mitral and tricuspid regurgitation in cancer patients is also approached with transcatheter treatment. Development of mitral regurgitation in cardio-oncological patients can occur via two mechanisms. The first is primary mitral regurgitation caused by radiation-induced valve disease, as described previously. The second is functional mitral regurgitation caused by underlying dilated cardiomyopathy. While radiation therapy can lead to myocardial fibrosis and ultimately myocardiopathy through similar mechanisms as described previously, multiple traditional chemotherapeutic agents can cause ischemic or non-ischemic cardiomyopathy. Additionally, immune checkpoints inhibitors have been shown to cause cardiovascular adverse events, with cardiomyopathy or myocarditis being among the most concerning. Although less common, chemotherapy induces dilated cardiomyopathy, and radiation therapy can result in the development of severe symptomatic tricuspid regurgitation. For patients with symptomatic primary mitral regurgitation, surgical interventions with mitral valve repair or replacement is recommended, with levels of recommendation ranging from 1 to 2B. In symptomatic secondary mitral regurgitation, there is a level of 2B recommendation for surgical interventions. Despite the abundance of data for surgical mitral valve interventions, there is little data for mitral valve replacement in high-risk patients with concomitant malignancy. However, in the past decade, the use of transcatheter mitral valve edge-to-edge repair with mitral clip device has been evaluated with yielded promising results. Its use in severe degenerative mitral valve regurgitation has resulted in similar outcomes and superior safety when compared to surgical mitral valve repair or mitral valve replacement, and as a result now holds a Class 2B recommendation in patients with prohibitive surgical risk. Given the positive safety profile of transcatheter mitral valve repair in high-risk patients, its use has expanded in the population of cancer patients who are deemed to be prohibitive surgical interventions. Despite the abundance of data for surgical mitral valve interventions, there is little data for mitral valve replacement in high-risk patients with concomitant malignancy. However, in the past decade, the use of transcatheter mitral valve edge-to-edge repair with mitral clip device has been evaluated with yielded promising results. Its use in severe degenerative mitral valve regurgitation has resulted in similar outcomes and superior safety when compared to surgical mitral valve repair or mitral valve replacement, and as a result now holds a Class 2B recommendation in patients with prohibitive surgical risk. Given the positive safety profile of transcatheter mitral valve repair in high-risk patients, its use has expanded in the population of cancer patients who are deemed to be prohibitive surgical risk. In a registry-based study of 800 patients evaluating outcomes of patients with multiple non-cardiac comorbidities and who underwent transcatheter mitral valve repair, 52 had concomitant malignancy and were on palliative care. This group patients was found to have significant improvement in clinical symptoms at 30 days with no difference in peri-procedural complications when compared to patients without non-cardiac comorbidities. A recent retrospective study utilizing the national inpatient sample revealed that there was been a significant rise in transcatheter mitral valve repair, utilizing from 1.8 to 40% in patients with cancer between 2012 and 2015. This is particularly attributed to increased cancer survivorship in addition to the overall higher presumed surgical risk for cancer patients with mitral regurgitation. It also attests the overall safety of transcatheter mitral valve repair. This study, 700 patients with cancer underwent transcatheter mitral valve repair and were found to be no significant difference in stroke or in hospital mortality when compared to cancer patients who underwent surgical mitral valve interventions. Additionally, when compared to cancer patients who underwent surgery, there was a decreased rate of major bleeding and higher likelihood of home discharge. Of note, although the results of these studies are encouraging, it did not differentiate between primary or secondary mitral regurgitation. Randomized controlled trials evaluating transcatheter mitral valve regurgitation have evaluated patients with secondary mitral regurgitation due to the underlying dilated cardiomyopathy and primary degenerative mitral regurgitation. However, it should be recognized that in patients with history of cancer and mediastinal radiation, primary mitral regurgitation induced by radiation-associated fibrosis and calcification of the aortomitral curtain is the most common etiology. 14 patients evaluating outcomes of surgical mitral valve interventions in patients with prior history of mediastinal radiation, the patients were found to have a poor survival and poor durability of surgical repair at 5 years. A slightly larger registry of 150 patients almost undergoing mitral valve surgery with a prior history also of mediastinal radiation revealed a 5-year survival rate of only 55%, with no significant differences between surgical mitral valve repair or replacement. And despite these poor outcomes in mediastinal radiation-associated mitral valve disease, there is limited data evaluating the use of transcatheter mitral valve repair in population. The only published study of MitraClip in patients with a history of radiation-induced mitral regurgitation considerably suitable for this intervention is very small, only with 15 patients. It revealed promising results. Patients experience echocardiographic improvement of mitral regurgitation with sustained improvement in systems at 2 years follow-up. The development of stenosis should be avoided at the time of MitraClip procedure. Late mitral valve stenosis may be an unpredictable and progressive event that is potentially related to sustained reactive damage of the mitral valve apparatus following mediastinal radiation. Close surveillance is therefore required to identify and appropriately manage late mitral valve stenosis following MitraClip implantation. To recognize the effective impact on mitral regurgitation, MitraClip may reverse pulmonary hypertension and improve even tricuspid regurgitation, thus avoiding unnecessary concomitant tricuspid treatment if the surgical option for mitral regurgitation has been considered. Evidence regarding surgical approach to tricuspid regurgitation in cancer population with radiation valvular disease is even scarce. A small cohort registry of only 6 patients evaluating outcomes in patients with a history of mediastinal radiation undergoing surgical tricuspid valvular repair also revealed poor outcomes and poor durability of the tricuspid valve intervention. And although the sample size in this study was limited, it highlights the growing need for a non-surgical method of tricuspid valve repair. Currently, in European guidelines, only surgical tricuspid valve annuloplasty or replacement is recommended for the management of severe tricuspid regurgitation. Unfortunately, there is little data on tricuspid valve interventions in high-risk surgical patients, including those with concomitant malignancy. And as a result, many patients with severe tricuspid regurgitation and resultant right ventricular dysfunction are managed medically with suboptimal long-term outcomes. In the past several years, as for mitral valve, transcatheter tricuspid repair has emerged as a possible alternative to surgical intervention for tricuspid valve disease in patients with prohibitive surgical risk. Numerous transcatheter methods of repair are currently being evaluated, which include direct suture annuloplasty, direct ring annuloplasty, coaptation enhancement, and valve replacement. Transcatheter tricuspid valvular repair development is, of course, in its infancy, but given the positive outcomes of transcatheter mitral valve repair, there is particular interest in the study of devices that achieve coaptation enhancement. Off-label use of MitraClip device in performing edge-to-edge repair has been evaluated in the tri-valve registry. There was a 77% procedure success rate with improvements in the tricuspid regurgitation severity and New York Heart Association at 1 year follow-up. The combined rate of mortality and unplanned hospitalization for 1 year was 35%. The triluminate trial is examining the safety and effectiveness of transcatheter tricuspid valve regurgitation with a novel TriClip system, which uses the same edge-to-edge repair technique as the MitraClip device. Based on preliminary 6-month outcomes of this trial, 85 patients high-risk surgical underwent tricuspid valve repair with no peri-procedural complications and at 30 days, and 86% of patients had decreased tricuspid severity with improved clinical outcomes. The former tricuspid transcatheter valve repair is a foam-filled balloon that is placed with the tricuspid annulus over a rail that is anchored in the base of the right ventricle and increased leaflet coaptation by occupying the regurgitant orifice area. A register of only 19 high-risk surgical patients who underwent transcatheter tricuspid valve repair with former device reported a high procedure success rate of 89%, no deaths at 30 days, and a significant improvement in tricuspid regurgitation sustained at 3 days. Although none of these studies is specifically evaluating implementation of transcatheter tricuspid valve repair in patients with active cancer or history of mediastinal radiation, it may be reasonable to consider the applicability of this minimally invasive procedure on a case-by-case basis. So, I leave you with some thoughts and considerations. Early stage cancers may benefit from aortic stenosis treatment just as non-cancer patients, since outcomes of most cancer types are significantly improved with modern therapy. Due to the minimally invasive nature of TAVI compared to aortic valve replacement, TAVI should be preferred in cancer patients. In patients with a remote history of cancer and radiation-induced aortic stenosis, TAVI is by far the most useful intervention, especially in the presence of the named hostile thorax. And it may be reasonable to consider the applicability of minimally invasive procedure as transcatheter mitral valve repair and transcatheter tricuspid valve repair in patients with active cancer or a history of mediastinal radiation on a case-by-case basis. So, definitely need robust registry-based and prospective trials are required to meet the growing needs that are needed for this cardio-oncologic patient population. Thank you.
Thank you, Dr. Claudia, for a wonderful presentation and a very comprehensive one at that, because this is truly an absolutely enormous topic, which encompasses a lot of things. And perhaps because there are so many things to consider in cancer patients and in structural disease, I've actually got quite a few discussion topics for you. So I would start with the aortic stenosis, perhaps. And so you were quite clear, and I couldn't agree more, that TAVI should be preferred in cancer patients as a whole. I would say that one of the challenges today, because there's been such a progression in the treatment of cancer patients, is actually convincing colleagues that intervening on those patients is useful, because we still tend to think of cancer patients, including metastasis patients, as patients with a very short survival. But advances in cancer therapy have shown us that that's often not the case, and patients do live on for years. And so I guess that my question would be about optimizing risk, first of all, in TAVI patients. So are there any particular concerns or methods that you think would be especially relevant in cancer patients pertaining to access sites? Because access complications are still an important problem in TAVI. And so when I'm saying this is in addition to transfemoral, do you think that we should more often try other forms of access like transcaval or axillary, for example? Do you think there are some sorts of methods that should be avoided for closure devices? We're now using the MANTA device, which is a plug. Some would say that there may be an increased risk of infection in cancer patients because of changes in inflammatory responses. What's your take on that? I know it's a very opinion-based answer because there's not a lot of evidence, but what's your opinion on that?
Yes, that is very, very interesting topic, and that is very good question. So I don't know if just regarding some of issues, when we study a patient for TAVI, we do a complete angio CT study. So we are very, very aware of our complications that we might have during our procedure. So we know specifically how the vascular assays are regarding calcification. That might be an issue. Fibrosis also, and this is very, very special in patients that undertake an radiotherapy. And one of the issues why surgeons are very not very keen on doing aortic valve replacements. So, but if you do prefer one of the types of the vascular assays, I would say that transfemoral would be the best, because otherwise we could go for an transapical TAVI for an axis, and that will also would require that the surgeon would take a minimally invasive approach of the thorax. That can also be very challenging. So if you are talking about a very fibrotic thorax, namely achieving all the pericardial and the apex of the left ventricle. So other also approaches like a subclavian one, or even a minimally approach also for the aortic, probably would not be so favorable. So I would say that transfemoral even would be the better one. Of course, that for all the approaches, as for surgery, we have also the other complications that may have complications associated as infections ones. But I think that you can definitely use the devices that are able to close it as Manta or even per-close devices with some safety. In our experience, and this is very, very case-based and the personal experience, we didn't have any kind of infectious experiences in patients that had cancer or cancer-free patients. So I would say that would be a very safe approach, and that we can definitely do it.
Thank you. Wonderful response, I think. Another question also, still with regards to TAVI, and still a little bit more technical. We're going to get a little bit more into drugs. So we see this answer quite frequently from some colleagues who are less experienced in dealing with cancer patients, which is proposing the use of balloon valvuloplasty in cancer patients because you're not so sure about the survival of whether they'll be able to take a full-scale TAVI procedure. Do you think we should use that as a bridge, or more often in cancer patients? Or on the contrary, do you think that it's too risky? TAVI has gotten to a mature enough procedure that we should use TAVI as a default and only seldom balloon valvuloplasty?
Also very good question. So balloon aortic valvuloplasty is definitely gaining some strength along cancer patients. So in the past, we almost were not using it, and now we are using several times. So I think that we can have two types of approaches, and mainly in this kind of treatment, which should look to patient prognosis. So if we are really talking about in a very symptomatic patient, but we know that it's probably a stage 4 or a metastatic cancer, and we still want to give some quality of life to that patient and minimize symptoms like heart failure, I think that would be a very, very nice approach to do only aortic valvuloplasty. But if we are talking about a patient that we know that is on remission or a stage 1 and that needs cancer therapy, I think we should really invest in those kind of patients. Of course, they are cancer patients, but they deserve our best practice for the time being. And so in that kind of patients, I think that definitely you should use a TAVI approach as default.
Thank you. Very clear as well, Claudia. So last question in regards to TAVI. How do you view the results of the popular TAVI trial? Some are moving on completely to a single antiplatelet strategy following TAVI, whereas always are moving on to keeping with that because they feel the trial is too small and it's just one trial. What's your take on that, especially if you were considering this strategy for a cancer patient?
Once again, I think that we should evaluate previously the bleeding reach and that we should do it according to that. But I think that the popular TEVI gave us some very specific and straightforward data regarding mono or dual antiplatelet therapy. And for the time being, I think that we are gaining some terrain in the single therapy, a monotherapy only, and that should not stop us from treating this kind of patients.
Thank you. Okay, so moving on to mitral now. It's perhaps more challenging because there's quite little data here. So you were quite clear on TAVI as saying that it should be the standard for cancer patients, and I couldn't agree more. What about mitral? Do you think that, and specifically MitraClip, which is what's mostly available, do you think that MitraClip, if feasible, should be the default strategy for cancer patients, if feasible, of course?
Yes, if feasible, because that is one of the issues. It's this, most of the patients are not feasible. If you noticed, one of the issues is not being calcified. So less calcification of the valve and the apparatus, and that is not what we will find in cancer patients if they are subject to radiation. That will be fibrosis, that will be calcified. So we have to be very, very specific and very concerning when you are studying this kind of patients to see if they are really suitable or not suitable for this kind of approach. But if we are talking about dilated cardiomyopathy that can frequently happen when you're using and speaking about the chemotherapeutic agents, and even now with the newly approach with the monoclonal antibodies, that can be one of the consequences in these patients. I think that the perspective is a little bit different, and we can look to these patients a little bit more like our patients that have a cardiomyopathy without a degenerative mitral valve disease. So we have to look very, very carefully to this patient and understand what kind of patient do I have here? What is the main reason for this mitral regurgitation? Is this a primary one causing by radiation, or the component of that mitral regurgitation is more functional? And my approach will be more like a standard heart failure patient, and not specifically a cancer patient. But of course, that a case by basis is very, very, very important in this type of patients.
Okay, thank you, Dr. Claudia. I think that was very clear as well. Thank you for a very wonderful discussion, and we're right on time for moving on. Thank you very much.
Thank you. It will be my pleasure.
Okay, so it's now my great pleasure to introduce Dr. Julia Toste. Dr. Julia Toste is a cardiologist. She has also been, I would argue, one of the first cardiologists in Portugal as well to take an interest in cardio-oncology. She's the leading cardio-oncologist at Hospital de Luz in Lisboa, and it's a great pleasure to have her here with us today. And she will now give a talk on a very, very important topic, which is 5-FU-induced cardiotoxicity. Thank you, Dr. Julia.
Good morning. Thank you very much for the kind invitation to be here today talking about cardio-oncology. It is a great pleasure to start talking about 5-FU-induced cardiotoxicity. Indeed, fluoropyrimidines such as 5-fluorouracil or 5-FU form the foundation of a wide variety of chemotherapy regimens. 5-fluorouracil is the third most commonly used chemotherapeutic agent in the treatment of solid malignancies across the world, including gastrointestinal tumors. Fluoropyrimidines also possess radiosensitizing properties and are often used in conjunction with external beam radiotherapy. As with all chemotherapy, balancing the potential benefits of therapy against the risks of drug-related toxicity is crucial when clinicians and patients make shared decisions about treatments. 5-FU is the second most common chemotherapeutic drug associated with cardiotoxicity after anthracyclines. The most common manifestation of cardiotoxicity is chest pain, presenting as a typical chest pain, angina on exertion or rest, and acute coronary syndromes. The clinical expression seems to depend on the way 5-FU is administered. With bolus infusion, the patient can have classical angina and he may present with an acute coronary syndrome at the first cycle, during, or just after administration, and the ECG at presentation can show an ST segment elevation. Otherwise, with continuous infusion, the patient can have an atypical chest pain, intermittent and recurrent, and it can start about 24 to 72 hours after infusion initiation, and the ECG at presentation is usually normal. Other less common manifestations of 5-FU induced cardiotoxicity include atrial fibrillation and other arrhythmias, myocarditis and pericarditis, heart failure, and sudden death. It is still difficult to know the real incidence of cardiotoxicity with 5-FU. Indeed, different reports describe a wide range of estimates for the incidence of cardiotoxicity. This variability is the likely result of differences in the dose and method of administration, the use of other potentially cardiotoxic chemotherapeutic agents, concurrent radiotherapy, patients' clinical characteristics, and variability in the definitions of cardiotoxicity. It can occur with a wide dose range. It is dependent on the schedule and route of administration. In general, risk appears higher with infusional as opposed to bolus FU regimens. With bolus regimens, the incidence of cardiotoxicity is between 1.6 to 3%, and with continuous infusional regimens of 5 days or longer, the reported range of risk is between 2% to 18%. So, cardiac toxicity has been estimated from 1.2 to 18%, with a mortality of 8% and a further increase of 13% in risk-posed subjects. The predisposing factors are a pre-existing coronary heart disease, the genetic deficiency of dihydropyrimidine dehydrogenase, present in 8% of normal population, that prevents the possibility to metabolize 5-FU, and the supplementation of folic acid, which stabilizes 5-FU. Coronary vasospasm is a leading theory for 5-FU-related myocardial ischemia. Patients with coronary vasospasm may have ECG findings suggestive of coronary occlusion, including ST segment elevation, as well as biochemical evidence of myocardial injury with troponin elevation, even in the absence of occlusive macrovascular disease on angiography or CT of the coronary vessels. This figure seeks to show different pathways of cardiotoxicity by 5-FU. Our biggest concern is ischemia. In some cohorts, coronary artery vasospasm has directly been visualized during coronary angiography, as has brachial artery vasoconstriction immediately following the administration of 5-FU injections. Vasospasm can be related to an endothelial-dependent mechanism based on the endothelial dysfunction or an endothelial-independent mechanism, the called primary smooth muscle dysfunction. In addition, rheological side effects must be considered. Other pathological mechanisms that could contribute to 5-FU-induced cardiotoxicity with other manifestations like myocarditis, Takotsubo, or heart failure include factors that cause direct cellular damage. Animal studies have demonstrated gross pathological changes to cardiomyocytes in a dose-dependent fashion, as well as directly to endothelial cells. So, what to do if the patient needs 5-FU to treat his cancer and he has symptoms of myocardial ischemia during infusion? It is widely accepted that rechallenge after documented cardiac toxicity without a change in original drug dosing is associated with recurrence cardiotoxicity rates as high as 80% and reported death rates as high as 18%. That's why reintroducing 5-FU to patients with a history of cardiotoxicity following prior 5-FU administration was not advised some years ago. So, what are the possible alternative treatment options? Discontinuation of the fluoropyrimidine with or without switch to a second-line non-fluoropyrimidine regimen, dose reduction by 20 to 50% dose and retreat with the original drug, switch from infusional to bolus 5-FU. Toxicity may be more likely related to accumulated metabolites than peak dose. The addition of some combination of nitrates and calcium channel blockers has been a consistent part of every rechallenge protocol. This figure tries to show how to manage in front of a patient with chest pain during 5-FU. First of all, discontinue 5-FU, administer calcium channel blockers and nitrates and treat other symptoms. Then establish diagnosis. Determine if further 5-FU is needed. If no, pursue alternative therapy. If yes, is this patient high risk for coronary artery disease? If no, do a non-invasive test like CT coronary angiography. If it is negative, try to rechallenge with 5-FU as bolus regimen, pre-treat with calcium channel blockers, nitrates, and closely monitor. If this patient is high risk for coronary artery disease, do a coronary angiography. If there is significant coronary artery disease, revascularize and then try rechallenge with 5-FU and closely monitor. If there is no significant coronary artery disease, you have the diagnosis of 5-FU related cardiotoxicity, so avoid further 5-FU and capecitabine. Here is a proposal for 5-FU cardioprotection algorithm. First of all, switch to bolus, not continuous infusion 5-FU. About 3 to 4 hours prior to infusion of 5-FU, do nifedipine based on blood pressure and oral isosorbine mononitrate based on blood pressure. During infusion, you must give diltiazem 1 hour after start, and for the 5-FU push over 12 to 15 minutes, cardiologists must be present. Have sublingual nitroglycerin and short-acting nifedipine available for any recurrent chest pain or equivalent. Monitor patient for 90 minutes. Post-treatment, about 12 hours after first medication, repeat nifedipine and disorbate mononitrate, and 24 hours after treatment, repeat nifedipine. So, the fluoropyrimidines continue to be the cornerstone drug in the treatment of gastrointestinal and other solid tumor malignancies. Treatment-induced chest pain may lead to discontinuation of effective and potentially curable chemotherapy. There is no universally accepted approach to re-challenge once cardiac chest pain is suspected or documented. Several alternative strategies have been reported that include chemotherapy without fluoropyrimidines, or dose reduction, or switching from infusional to bolus regimen, and the addition of cardioprotective antispasm medication, nitrates, and calcium channel blockers. So, every patient should have a cardiac history documented and a baseline pre-treatment ECG to be used mainly for comparison. Every patient should be instructed to immediately report any chest discomfort or pain or perceived shortness of breath associated with their treatment. Proactive patient education about manifestations of ischemia during 5-FU treatment is very important in potentially high-risk patients. The presence of stable coronary artery disease should not be an absolute contraindication to appropriate oncologic use of these drugs, with decisions and use made on a case-by-case basis. Patients presenting as acute coronary syndrome generally have ST segment elevation and present with the first bolus exposure to 5-FU. The absence of an acute coronary syndrome-like presentation is characterized by recurrent symptoms that may be atypical, that progressively occur earlier after each cycle initiation, with increased frequency and severity during continued treatment. So, if there is a good alternative, use it. If there is no good alternative and the regimen is effective from an oncological standpoint, pursue safe re-challenge. Re-challenge under closely supervised conditions with the addition of some combinations of nitrates and calcium channel blockers. Thank you very much for your attention.
Thank you very much, Dr. Julia, for such a clear and systematic presentation. So I guess I would start just before opening the questions for everyone. I would just start by asking you a question that it's actually something that I often think about with these patients. So quite often patients are taking beta blockers at baseline for many reasons, most of the time for hypertension, but sometimes also because they may have baseline arrhythmias such as atrial fibrillation and so forth. And quite frequently what happens is that 5-FU is started in patients who are already on this medication. This medication is not previously adjusted. Do you think that there should be some sort of recommendation on our behalf to always make the switch for calcium, non-dihydropyridine calcium channel blockers by default? Do you think that this is something that we should address more routinely?
Thank you for this lovely question. I don't think we must change, because in truth, we don't know which patient is going to do the vasospasm. So I think at first, when we start, the patient must be optimized. If he is optimized with beta blocker, I think we don't change to calcium channel blocker before he has any manifestation. But if he starts having chest pain, here I think we must change to diltiazem or to verapamil, but when he starts having chest pain, because some patients who had already pre-existing coronary disease, they were okay under beta blockers, and they didn't have spasms. So we don't know if this patient is going to do a vascular. In that study, they already seen that patients younger and without pre-existing coronary artery disease could have vasospasm. And so in that, I think that we have to start calcium channel blockers. But I don't think we must change in a well-controlled patient.
Thank you very much. I would argue that also one of the challenges that the vasospasm diagnosis is still a very presumptive one, right? So we look at the coronary angiogram, and if we don't see anything in there, we assume that it was probably vasospasm, but we're still not routinely doing that in Portugal. Although I'm very hopeful that that'll change very soon. So I think it'll be another help. Okay, so I would open to questions from the audience. Anybody would like to pose questions to Dr. Julia?
Good morning to all, and good morning to Dr. Julia. Thank you for your clear presentation. And I would like to ask you about risk stratification before the therapy. Which patient do you think that should be seen by CardioOncology or the general cardiology before starting the therapy?
I think in an ideal world, every patient who are going to do fluoropyrimidine should be seen by a cardiologist, but we can't do that. It's not we don't live in a world which is ideal. So I think, first of all, the patients with pre-existing coronary artery disease or with pre-existing cardiovascular risk factors. And if a young patient without any disease is going to start fluoropyrimidines, like patients who have gastrointestinal tumors, or those patients which have to do radiosensitizing and they are going to do capecitabine. I think they must be instructed immediately to say if they have any chest pain, because I think the oncologist has here a very important paper in the educational. So lots of times I think patients don't know that just chest pain is because of the medication they are doing. And sometimes they go to the emergency and the patients don't know there is a relationship. So sometimes fewer now, but they don't stop the medication. They still do the medication, and it can be acute coronary syndrome or other something that we could prevent. So I think the education is the first point. I think that's it.
Okay, any other questions from the audience? I remind you that you can also place questions on the chat. Just send it to everyone and we'll see it. So you don't necessarily have to talk if you're not very much in the mood for that.
Perhaps I could put a question. But first, I would like to thank you, Julia, for addressing this not so easy issue, okay? Because this is the kind of issue that the oncologists ask for help. And we don't have a straightforward answer, right? And because sometimes these patients are older patients, in our experience with colon cancer generally, and they have thoracic pain only during the FU administration, right? We don't know, sometimes they don't have even previous cardiac disease or myocardial infarction and so on. So we don't know exactly what to recommend. Usually we recommend a calcium blocker, channel blocker. Okay, but sometimes we advise to put a transdermic vasodilator, and sometimes it's useful because the patient don't refer any more pain during the administration. Anyway, in a recent study you just mentioned, those older patients with already on medication, they had little less frequent vasospasm than the other ones, the younger ones that were not medicated. Anyway, the outcome, the cancer and the cardiac outcome was identical. There was no difference in outcomes, and that's reassurance. Okay, thank you.
Yeah. When you see in the literature, it's always about nitrates and calcium channel blockers. Anyway, I usually give also aspirin because we know if there is a long vasospasm, we can have a thrombus. And I think urological also must be considered. So I usually also give aspirin when the patient is going to do lots of these treatments. And so for the cycles, there are very patients who respond in the challenge with calcium channel blockers, nitrates, and I also give aspirin.
Okay.
Thank you, Professor. Thank you, Dr. Julia. So I'm not seeing any further questions here from the audience. So I believe we can quite possibly move on to the next session. Dr. Julia, please.
Thank you. So now it is a pleasure to introduce our Dr. Andrea Magalhães, which is a cardiologist in Santa Maria Hospital and also in the scientific committee of this course. She is also a member of the nucleus of the CardioOncology working group of the Sociedade Portuguesa de Cardiologia. And we are going to listen Dr. Andrea Magalhães talking about hypertension management in cardio-oncology patients. Go ahead.
Good morning. My task today is to talk with you about hypertension management in cardio-oncology. As we all know, hypertension is a very prevalent disease. More than 1 billion people worldwide have hypertension. And despite all the evidence related to the complications of this disease and the existence of highly effective lifestyle and drug treatment strategies, controlling hypertension remains a major issue. In Portugal, more than 40% of the adult population has hypertension. Only 1/4 are treated and very few have their blood pressure under control. So hypertension remains a major preventable cause of cardiovascular disease and all-cause mortality globally. In cancer patients, is the most frequently reported comorbidity. Early diagnosis and treatment in these patients is very important, especially because hypertension is considered a risk factor for cancer therapy-induced left ventricle dysfunction. And so directly or indirectly can lead to the discontinuation of cancer treatment, which may have an important impact on prognosis of our patients. The incidence and severity of hypertension in cancer patients depends on many factors. The existence of risk factors for hypertension, such as obesity or sleep apnea, the degree of control of a pre-existing hypertension, the presence of an established cardiovascular or chronic kidney disease. Some cancers are more associated with hypertension. This is especially true for renal cell carcinoma. Patients with this cancer may have a prevalence of hypertension that exceeds 75%. Hypertension can also be a paraneoplastic manifestation of some cancers. In what concerns cancer treatment, many agents can lead to increase in blood pressure, but this is especially an issue with the vascular endothelium growth factor inhibitors. Angiogenesis is a fundamental process for the tumor growth and proliferation, and the VEGF signaling pathway is one of its main modulators. The development of drugs that interfered with this signaling pathway show very important results in many cancers, such as renal cell carcinoma, thyroid cancer, some breast cancer. And these drugs can be antibodies directed against the factor or against its receptor, or can also be tyrosine kinase inhibitors that interfere with the signaling pathway of the receptor. In clinical trials, the incidence of hypertension with these agents range from 15 to 40%. However, because of the varying definitions of hypertension use, for instance, some trials considered hypertension only if the systolic blood pressure was above 150, the true incidence may be underestimated. And in fact, the newer trials show very bigger numbers. And how these agents cause hypertension? The main mechanism is by increasing the systemic vascular resistance, either by reducing the production of nitric oxide and increasing endothelin, and this leads to an increase in vasoconstriction, but also due to capillary rarefaction. The renal effects of these drugs are important too, because of the decrease of natriuresis and the fluid retention that obviously contributes to development of hypertension. The individuals treated with these agents show important increases in blood pressure, especially in the first week of treatment. And this happens in the normotensive patients and in the previously hypertensive patients. In one study recently published in the JACC CardioOncology, more than 80% of patients previously treated for hypertension needed an adjustment during the treatment with VEGF inhibitors. And about 17% of patients that were normotensive needed to start treatments. It's important to say that the blood pressure values return to baseline in most of the patients, usually after 1 or 2 weeks after the drug discontinuation. Hypertension induced by these agents is transient and it's dose dependent. Some studies suggest that highly selective agents such as axitinib may have a more pronounced impact on blood pressure levels. So blood pressure elevation is considered an on-target effect of these agents and reflects effective inhibition of the VEGF signaling pathway and is considered a marker of cancer response. However, it's important to say that there is no evidence that the control of blood pressure affects this anti-cancer activity. Some adjuvant therapies can have an impact on the rise on blood pressure too, especially anti-inflammatory drugs or corticosteroids. What concerns management of hypertension in these patients, I would like to go through 3 important points: the pre-treatment risk assessments, the monitoring during cancer treatments, and the treatment of hypertension. In patients that are about to start treatments with agents that can increase blood pressure or that can lead to left ventricular dysfunction, it's important to do a thorough history, including the identification of a pre-existing hypertension, the degree of control, the existence of hypertension-mediated organ damage. It's important to do a global risk assessment too. And of course, we need to measure the blood pressure. It's important to bear in mind that there are some factors like anxiety and pain that can interfere with our management, with our measurements, and we should address it. And the purpose of this assessment is not to exclude patients from the therapy, but to efficiently address the risk of potential complications, and in that way establish preventable measures. If we detect hypertension, even if it's a grade 1 hypertension in patients that will be treated with VEGF inhibitors, we should start treatment. And it's important to bear in mind that we should not start the VEGF inhibitors if we don't have the blood pressure under control. In what concerns monitoring, we should do blood pressure measurements in office weekly during the first cycle of treatment, and then at least every 2 to 3 weeks for the duration of treatment. Of course, we may have to do it more often if blood pressure is not controlled. Home blood pressure monitoring is recommended, especially in the first week and in patients on antihypertensive therapy or that needed an adjustment of their antihypertensive treatments. 24-hour ambulatory blood pressure monitoring is a useful tool, but it's more reserved to high-risk patients or when blood pressure is difficult to control. What concerns the goal of treating hypertension, the targets in this particular group of patients treated with VEGF inhibitors is not well established. So we use the ESC guidelines targets. So in patients under 65 years, systolic blood pressure should be between 120 and 129. For older patients, the target is to have blood pressure between 130 and 139. It's important in all hypertensive patients to address lifestyle modifications, especially in what concerns diet and exercise. And in cancer patients, is this also true? But it's important to say that we should tailor these lifestyle modifications to the general condition of the patient. There are no evidence of or clear evidence of which drug we should use in patients with VEGF inhibitors-induced hypertension. Usually, the first choice are the dihydropyridine calcium channel blockers or ACE inhibitors or ARBs. These last class of drugs are especially important for patients with heart failure or left ventricle dysfunction or patients with proteinuria. Only one study tried to investigate the change in blood pressure according to the antihypertensive treatments. And in this study done by the Stanford Institute of Cancer, calcium channel blockers have a more profound impact on blood pressure than ACE inhibitors. However, it's important to say that this study is retrospective and only renal cell carcinoma patients were included. Diltiazem and verapamil should not be used in patients treated with VEGF inhibitors, especially due to the risk of drug interactions because of the inhibition of the cytochrome that metabolizes VEGF inhibitors. Diuretics should be used with caution because of the risk of electrolytes abnormalities and interval QT prolongation. A dose reduction or a discontinuation in therapy with VEGF inhibitors should only be done if we can really not control hypertension. In that situation, we should aggressively treat the blood pressure to allow a rapid reintroduction of the treatment. This slide nicely sums up the hypertension management in cancer patients, and it highlights the key points. The need to do pre-treatment risk assessments, the close monitoring, and the treatment optimization, so that hypertension don't become a reason for stopping therapy. So my take-home message are that hypertension is a frequent comorbidity in cancer patients, and it's a common complication of cancer treatment, especially with VEGF inhibitors. Blood pressure should be assessed before and frequently during treatments. Active control of blood pressure is very important because it will allow patients to tolerate high dose of therapy and for the longest periods. Although there is no clinical evidence, dihydropyridine calcium channel blockers and ACE inhibitors or ARBs should be the first choice for the treatment of hypertension. Diuretics should be used with caution in this context. VEGF inhibitors should only be discontinued if we cannot really control blood pressure. Thank you for your attention.
Thank you very much, Andrea, for this excellent presentation. As you said, hypertension is a frequent comorbidity in patients with cancer, and VEGF inhibitors are a concern because of they give a high hypertension with severe hypertension. So, what is your suggestion for the better control of blood pressure in these patients? What is the first choice?
Thank you for your question, Dr. Julia. I think for treatments, as I said, my first choice usually are the calcium channel blockers. Except for the patients that we thought that may have better outcomes with ACE inhibitors, and that's are the patients with LV dysfunction, and in what concerns proteinuria, it seems to that ACE inhibitors or ARBs are better to in this group of patients. So that was my take on the which drugs to choose for treat these patients. But all we don't have many evidence to guide use on this. This is our clinical experience and what we read on the literature, that most of the times are experts' experience. We don't have many studies really really study the mechanism and looking at which drug should be used in this particular setting with this particular mechanism of action of these drugs.
And sometimes we have to use a lot of different medications to get the blood pressure in control, isn't it? Is that your option too, isn't it?
Yeah, you're totally right. Most of the times there are really high levels of blood pressure, and we don't we can't control blood pressure only with one drug. So we have most of the times to use combination therapy.
Yeah. That's what I think too. I don't know if there is other questions to Dr. Andrea. I have here one. I'm going to read. In patients with uncontrolled hypertension already treated with YECA or AR inhibitors and calcium antagonistas, which medications do you choose afterwards? In resistant hypertension, do you do alternative studies like polysomnography or others?
Okay, thank you for the question. So we usually start with ACE inhibitors, RBs, or calcium channel blockers, as I said, in the highest possible doses of these drugs and in combination. And if it's not enough, then we have to look for the patient. And if there's no high risk, and of course, these agents are used to a variety of cancer, so kinds of cancer. So we have to look, and if there's no problem, so they have no problem with volume depletion or electrolytes abnormalities, then diuretics will be my next choice, especially potassium, especially aldosterone or something like that, because it seems to be very good. It seems to have very good results in these patients, and if that it's not enough, we have to escalate the therapy. And if we have if the patient doesn't have a significant bradycardia, beta blockers are other option in that kind of class. Carvedilol and nebivolol are more used, especially nebivolol, because of the mechanism of action. It seems to increase a little bit the oxide nitric, so it could be another option to add to our drug combination. And the second part of the question, in resistant hypertension, yes, we have to bear in mind the patient that we have. If the patient has risk factors for other secondary hypertension, we should pursue it. If we think that it's really because of the drugs, and as we know that the blood pressure increase, it's dose dependent, we can try to reduce the dose and see in that way we can have a better control of the blood pressure. And as I said, we should pursue all our efforts to not to discontinue completely the drugs.
I don't know if there are other questions. Oh.
Let me just ask a question to Andrea. For those patients that don't have previous hypertension and only become hypertensive during the first cycle of the VEGF therapy, what do you think about another approach, so-called the pill on the pocket, just for that occasion? Because after that first cycle, the blood pressure turns to normal. Okay, what's your opinion about this approach?
Okay, first of all, not all patients have the same duration on treatment of these drugs. Of course, that we should be aware that the blood pressure rises when the drug is taken, and when it is discontinued, the blood pressure decreases. And this is something that we have to bear in mind and to educate the patient too. But as the study that I showed in my presentation said, in the consequent cycles of the drug, the blood pressure still rises. The peak of rise of blood pressure is in the first cycle, but there are patients that are treated for a long period of time with these drugs. So we really need to make sure that the blood pressure is under control. So the pill on the pocket or something like that, we should use it with caution, I think, and especially for patients that are well educated and that can monitor their blood pressure, and that they know which targets do we want. And I think the education on the setting it's very important. And of course, it is only for normotensive patients before the treatment, because we know that everybody has a rise on blood pressure, but hypertensive patients have bigger rises on blood pressure during the treatment.
That's true.
Here in the chat, there's another question. If you have EC inhibitor or ARA inhibitor of preference?
Okay, we don't have any evidence to base to answer that question, so I don't have any preference. It's the way I think all of us have some preference that we use in clinical experience, but for all our hypertensive patients.
So if there is no more questions.
I'd like to
oh, you have one.
just, yeah, just still one more question. So not pertaining to drugs or any of those things, a bit of a different one. So I'm a bit of a tech geek myself, and I have this BP device that measures BP and then sends it to the phone and to the cloud and so forth. And it's a passive measurement, so you have to take the measurement, but you don't have to record it. Do you think that there's a role for this in these kinds of patients, because they have to come to the hospital so many times, and so there's quite a few constraints? Do you think that this is something that should be thought of for these particular patients, that they should be given these kinds of devices while on treatment?
I think it's a very good question, and I think I agree it's good strategies for the both sides. I mean to say, from the clinician point of view, I think it's interesting if we can have a more close monitoring, especially during the first week, and especially when we have to change the dose of the antihypertensive therapy. So for the clinician, I think it's a good thing, and for the patient too. As we were saying, it's a way to educate the patient, to empower the patient, to the patient gets that it's an important thing to measure the blood pressure. So I think it's a very good option in this setting.
Thank you.
Are there more questions? So if no, I'm going to thank Dr. Andrea Magalhães for this excellent presentation and for the clarifications.
There's another question from the audience.
There is? Oh, yeah.
Right now.
Yeah. It appears. You consider nutrition and exercise in these patients? Is it possible to help them with these strategies?
A very good question. I love this question. Yes, I didn't explore so much in the presentation. I think for all hypertensive patients, non-pharmacologic measures are very important. And for these patients too. I think that we should have some caution, and our approach really depends on the patient that we have, and especially the general condition of the patient, the staging of his cancer. So, but in general, I think it's very important. We try to help the patient and give. And we have to go to multidisciplinary approach, and nutrition, and especially exercise in cancer patients, and we will have a discussion on that. I think it's a very important take. It helps to control blood pressure, and it helps in the cardiovascular outcomes and cancer outcomes. So I think it's a very important take.
Great, thanks. Thank you.
So I'm going to ask again because I've been surprised. Do you have more questions for Dr. Andrea? So if you don't have, I think we can end this brilliant session. Thank you, Andrea. Thank you all.
Thank you, Julia. Now, I ask Dr. Lousada to take the floor and introduce the next lecture. Thank you.
Good morning. I think this is a very important topic, pulmonary hypertension in the era of the modern care. Because the pulmonary hypertension, it's a hemodynamic state. And in the OMS classification, there are a lot of situations with pulmonary hypertension. And in these situations, there are in the group 2 and the group 3 and the group 4, the thromboembolism pulmonar chronic, there are a lot of situations when the hypertension pulmonary it's important in terms of the diagnosis and the therapeutics. Then Rui Plácido is a very expert medical to talk to us about the therapeutics and the diagnosis in this situation. Then, because in the pulmonary hypertension, there are a new group of therapeutics and new possibilities to these patients. Then Rui, it's the moment to talk about this.
Hello everyone, thank you very much for this kind invitation. It's a pleasure to be here presenting pulmonary hypertension in the era of modern cancer care. And first of all, I want to congratulate all the organizing committee for this fabulous course. As we know, pulmonary hypertension is an hemodynamic condition that can be present across several clinical entities. As far as we know, PH is present in about 1% of the global population, which increases up to 10% in people aged more 65 years old. As pulmonary hypertension progresses, there is an overload of the right side of the heart with consequent dilatation and onset of symptoms of heart failure. The natural history of PH is one of successive stages, the characteristics of which are mainly related to disease that causes the hemodynamic condition and the right ventricular function. And from the clinical point of view, we can classify the pulmonary hypertension in 5 distinct groups based on pathophysiological mechanisms, therapeutic approaches, clinical presentation, and hemodynamics. Group 1 relates to pulmonary arterial hypertension, when the disease process affects predominantly the precapillary vessels on the lung. Group 2, pulmonary hypertension due to left heart disease. It's very easy to imagine if we have some disease on the left side of the heart that disturbs the pumping function of the heart, the pulmonary vessels gets congested and the pressure increases. Group 3, pulmonary hypertension due to chronic lung diseases or hypoxia. Group 4, pulmonary hypertension due to pulmonary artery obstructions. We'll talk later on this presentation. And Group 5, pulmonary hypertension with unclear or multifactorial mechanism. In PH, both impaired perfusion caused by systemic low output and systemic congestion caused by impaired right ventricular function cause an insult to numerous organ systems. This leads to local liberation of soluble pro-inflammatory mediators and thus initiation of an inflammatory cascade. This scenario is associated with systemic inflammation. During pH progression, there's a cascade of mechanisms and crosstalks between organs with several systemic consequences. Generally, and depending on the etiology of the disease, pH is a systemic condition that confers poor prognosis to the primary disease process. And when we talk on pH in cancer patients, there's a need to clarify the variety of pH subtypes in patients with a current or previous malignancy. The terms tumoral pulmonary hypertension indicates the most obvious cause of pH in patients with malignancy, the obstructions of pulmonary vessels by thrombotic or tumoral material. In other words, group 5 of the clinical classification. But it is not that simple. Pulmonary tumor microvascular disease includes both pulmonary tumor microembolism, PTE, and pulmonary tumor thrombotic microangiopathy, PTTM. These two conditions are likely to be a disease spectrum. Tumor emboli are frequently reported in autopsy specimens and may even be asymptomatic, and when pH does develop, progressive and fatal right ventricular failure occurs. Rarely, a large tumor metastasis can mimic a proximal pulmonary embolism, like in this movie, renal cell carcinoma invading the right heart. The clinical features including rapid onset of symptoms with pH and acute right heart failure that would be undistinguishable from pulmonary embolism by thrombotic causes. Tumor microembolisms is especially reported in cases of breast cancer, hepatocellular carcinoma, and choriocarcinoma. The other causes of pulmonary hypertension are cancer treatment related, and they will be discussed further on this presentation. In the context of tumoral pulmonary hypertension, pulmonary microvascular disease comprises PTE and PTTM, which can produce a similar clinical picture to chronic thromboembolic disease. PTE was described in early studies and defines the occlusion of the pulmonary microvasculature by tumor cells and associated thrombi. PTTM, pulmonary tumor thrombotic microangiopathy, which was described much later, from 90s, yields a similar clinical picture and is characterized by more extensive remodeling of pulmonary vessels in association with nests of tumor emboli. These two conditions are more commonly a post-mortem diagnosis, although PTTM has been increasingly reported in living people in recent reports. But as I said before, PTE describes the occlusion of small pulmonary arteries by nests of tumor cells without causing pulmonary metastases. Early descriptions include PTE with subacute cor pulmonale in the early 30s, and autopsy studies suggest that the diagnosis of PTE is greatly underestimated, showing that 3 to 26% of patients with solid tumors have evidence for neoplastic emboli. PTTM is characterized by the presence of pulmonary vascular tumor microembolic nests with evidence for activation of coagulation, obliterative intimal proliferation, and ultimately pulmonary hypertension. Like PTE, PTTM typically relates to a carcinoma, usually an adenocarcinoma, including gastric cancer and also breast, lung, bladder, ovarian, liver, gallbladder carcinoma, and also choriocarcinoma. An autopsy series of carcinomas suggests that the reported prevalence of PTTM is about 1 to 3%, and the most reported cases of PTTM have been described in Japan, likely reflecting their high prevalence of gastric adenocarcinoma. We know that PTTM occurs in about 16 to 27% of cases of gastric carcinoma, especially the mucinous type, signet ring, and poorly differentiated subtypes. And we need to be aware of this entity because like PTE, PTTM may present as pulmonary hypertension of unknown origin. And it is clinically identical to PTE, only distinguishable from PTE by histological examination. Until recently, PTTM was only an autopsy finding, but recent advances include ante-mortem diagnosis and some improvements in short-term outcomes. In more recently described cases of PTTM, there appears to be an intimate association between nests of tumor cells and the surrounding fibrointimal proliferation in pulmonary arteries and veins, which ultimately leads to vessel occlusion. We know that the proliferating intimal cells are both endothelial and non-endothelial in origin. Cancer cell attachment is postulated to cause endothelial cell damage, activation of coagulation, and initiation of proliferation through growth factors and cytokine release, including tissue factor, vascular endothelial growth factor, and PDGF, that is known to initiate macrophage recruitment and upregulate VEGF on cancer cells, which may further increase endothelial cell proliferation. Interestingly, imatinib, through PDGF inhibition, led to a recanalization of previously occluded small pulmonary arteries in a case of PTTM related to gastric cancer. Patients with PTTM and PTE usually present with progressive exertional dyspnea, hypoxia, and progressive right ventricular dysfunction. The onset is usually 3 weeks to 6 months prior to the presentation, and the physical exam is non-specific, include a prominent pulmonary second heart sound, raised jugular venous pressure, a right parasternal murmur, and also signs of right congestion and decompensation. The progression of symptoms correlates with CT findings prior to the onset of pulmonary hypertension. The test results are non-specific and reflect the presence of pulmonary hypertension. The EKG may show signs of right ventricular strain in the presence of pulmonary hypertension. Blood tests demonstrate raised D-dimers and NT-proBNP. Patients also desaturate markedly on 6-minute walking test. The pulmonary function testing would show pulmonary vascular limitation characterized by relative preservation of lung volumes but a very low DLCO. But one of the most important tools if there is any suspicion of pulmonary hypertension is of course the echocardiogram. The echocardiogram can show several signs of pulmonary hypertension like raised tricuspid regurgitation Vmax, pulmonary artery enlargements, and also indirect signs of pH on Doppler examination. VQ scan may show multiple small peripheral subsegmental perfusion defects not evident on CT scan with a normal ventilation. However, VQ scan do not distinguish the cause of pulmonary obstructions, and sometimes serial VQ scans may show resolution of perfusion defects following the treatments. The CT findings are non-specific and frequently includes nodules, the tree and bud pattern, septal thickening, and also infiltrates. But the confirmation of pulmonary hypertension, once suspected clinically, is done by right heart catheterization that will show a precapillary hemodynamic phenotype defined by a mean pulmonary artery pressure more than 20 millimeters of mercury at rest, a pulmonary capillary pressure below 15 millimeters of mercury, and a pulmonary vascular resistance more than 3 Woods units. And the prognostic hemodynamic variables in these patients are not related to the degree of elevation of mean pulmonary artery pressure, but with the value of mean right atrial pressure, cardiac output, and pulmonary vascular resistance. And at the time of right heart catheterization, pulmonary wedge aspiration cytology should be performed to detect tumor cells to attempt to confirm the diagnosis of PTTM or PTE. This technique has shown a good sensitivity and specificity, and it is reported in both PTTM and PTE, but it would not be possible to distinguish between these two clinical entities. Lung biopsy has been used to diagnose PTTM, however, it is advised caution in the presence of significant pH. Until recently, all case series reported death soon after diagnosis, and therapeutic measures start with supportive approaches like oxygen and anticoagulation when indicated, and the diagnosis has enabled more aggressive treatment of the underlying cancer in both PTE and PTTM using chemotherapy or targeted agents, and potentially in PTTM the use of antiproliferative approaches. The role for conventional pulmonary vasodilators is uncertain, and current evidence is based purely on reported cases. Regarding specific pulmonary vasodilators used on pulmonary arterial hypertension treatment, there is no evidence suggesting that the usual vasoactive mediators implicated in pulmonary arterial hypertension pathogenesis are anti-remodeling targets in PTE or PTTM. However, there is a rationale for their use to counteract the pulmonary vasoconstriction. However, despite some reports on hemodynamic improvements, there is no data showing better survival with these drugs given in combination with chemotherapy. Now another chapter. We know that malignancy is a risk factor for thromboembolism and also to the persistence of that material inside the pulmonary vessels. After cancer treatment, if there is criteria for chronic thromboembolic pulmonary hypertension, specific treatments should be offered depending on the levels of the obstructions. And they include surgical thromboendarterectomy and also balloon pulmonary angioplasty, a percutaneous approach, or pulmonary vasodilators, according to the guidelines. Now let's regard to the most frequent groups of cancer-related PH, the cancer treatment-related pulmonary hypertension. Several oncological treatments may promote the development of different subtypes of PH in patients with active or previous cancer, and these etiologies can be considered according to the clinical PH classification and of course may overlap with other causes of tumoral pulmonary hypertension mentioned above. And if we look in detail to the updated clinical classification, the group 1 concerns to pulmonary arterial hypertension due to intrinsic precapillary vessels involvement. Of cancer therapies that can potentially induce PAH, the clinical group 1.3, the tyrosine kinase inhibitors are highlighted. These kind of drugs include dasatinib, the most frequently involved, often used in chronic myeloid leukemia therapy, and ponatinib, bosutinib, and lapatinib, which are all used to treat several oncological conditions. Despite inhibiting relevant pathways including PDGF that might be expected to reverse PAH, this agent can cause direct pulmonary artery endothelial cell toxicity through the production of mitochondrial reactive oxygen species. Fortunately, the PAH usually resolves after discontinuation of the drugs, but can persist over a third of patients. And treatment with PAH-specific therapy is recommended for patients with right heart failure or persistent PAH after discontinuation of the tyrosine kinase inhibitors. We also know that several cancer treatment-related mechanisms may precipitate the onset of the rare pulmonary veno-occlusive disease, with a common mechanism likely to relate to venous endothelial injury from cytotoxic chemotherapy or radiation. PVOD is a devastating form of PAH characterized by widespread of fibrous intimal proliferation of septal veins and also often with pulmonary capillary dilatation and proliferation, and of course substantial remodeling of the small pulmonary arteries. Clinical features include marked oxygen desaturation, very low DLCO with a radiographic triad of interlobular septal thickening, pleural effusion, and lymphadenopathy. PVOD has been described in patients receiving chemotherapy, including gemcitabine and mitomycin C, and also in several reports following bone marrow transplantation. Radiotherapy has been reported to induce PVOD with a potential delay in onset for several years. Again, the mechanisms is thought to relate to radiotherapy-induced venous endothelial damage. And it has been suggested that therapy-induced PVOD may be under-recognized by a recent series of patients who died with pulmonary graft versus host disease more than 1 year after allogenic hematopoietic stem cell transplantation, where 34% had histological evidence for PVOD, as well as 29% having evidence for obliterative bronchiolitis. Finally, in terms of chemotherapy or radiotherapy-induced PAH or PVOD, there is an urgent clinical need to identify preventive adjuncts. Given the likely initial endothelial injury, cytoprotective approaches, including aminofostin, the only agent approved by the FDA as a clinical ionizing radiation protector and is active metabolite, acts as a radical scavenger to protect against lung and soft tissue fibrosis. Also, steroids can be considered in some cases. Now, pulmonary hypertension due to left heart disease. As we know, chemotherapy, especially with anthracyclines and radiation, can also cause left ventricular dysfunction with the potential onset of group 2 pulmonary hypertension. Here, there's no role for pulmonary vasodilators, and this kind of left ventricular dysfunction will be discussed afterwards on this course. In addition, and just to finish and to complete all the big lists of potential causes of PH in patients with cancer, some cytotoxic chemotherapeutic agents or frequent radiotherapy can cause pulmonary interstitial abnormalities and hypoxemia, which may lead to the group 3 of pulmonary hypertension. As in the last type of pulmonary hypertension, group 2, in the group 3, there's no role for specific vasodilators to improve the prognosis. And in conclusion, pulmonary vascular disease in cancer patients is relatively frequent and is associated to a worse prognosis with multiple potential causes with different treatment strategies. The diagnosis of pulmonary tumor embolism and the pulmonary tumor thrombotic microangiopathy can be difficult ante-mortem, but with increasing recognition of these conditions, therapeutic strategies are improving the outcome. And of course, further understanding of malignant causes of PH is clearly needed. Thank you very much for your attention.
Thank you, Rui, for your excellent, very excellent presentation, very complete. And a practical question. When the patient in the history of this cancer patient, this patient go to a specific center of hypertension, pulmonary hypertension. When it is the moment in this story that the patient go to the hypertension center to define the right catheterization and the other measures?
Okay, very good question. Thank you very much, Dr. Nuno. So it is important to reinforce the idea that in cancer patients, there's such a huge number of potential causes of pulmonary hypertension. So, and we need to look, first of all, for the most frequent causes. Of course, we need to take the medical history of the patients and know about all kind of drug that the patient took already take in the past or is taking now. And it is important to stratify the patient according to the most frequent causes. And to start, we know that patients with cancer have a very high probability to have, for example, a thromboembolism. And especially after a thromboembolism, we know that a patient with cancer have an increased risk to develop the chronic thromboembolic pulmonary hypertension. And in those patients, we need to be aware that there is specific treatment to offer in a form of surgery or balloon pulmonary angioplasty, or even if there is very distal obstruction, treatment with specific vasodilators, namely the riociguat. But in those kind of patients, it is sometimes very difficult to decide when to intervene, because sometimes the prognosis regarding the cancer is poor, and in those cases we will not refer a patient for a big surgery with an increased risk of a bad outcome if the patient has a already poor prognosis due to the cancer state. And sometimes the patient has a cancer already non-treated or receiving the specific therapy, but the patient is very decompensated. So we need to establish a strategy to overcome the heart failure. And sometimes we offer, for example, specific vasodilators as a bridge to treatment, to treat cancer. And then after the cancer treatment, we can offer the definite treatment strategy. On the other hand, we need to look, of course, to the probability to have a group 3 or pulmonary involvement due to the drugs. And in those kind of patients, we do not need a specific approach in a PH center, because in group 3, due to hypoxia or chronic lung disease, we should not offer specific vasodilators, as in patients with pulmonary hypertension due to left heart dysfunction. In those patients, there's no specific pulmonary hypertension therapies to offer. But of course, if we have a patient that is on tyrosine kinase inhibitors, there is a potential cause to pulmonary arterial hypertension, group 1. For sure, those kind of patients should be referred to a PH center to stratify the risk and to offer the best treatment strategy. We know for that kind of patients treated with tyrosine kinase inhibitors, is not rare to develop PAH, pulmonary arterial hypertension. And we know that after the suspension of the drug, 2/3 of the patients will stay in the long-term follow-up without PH, without therapy. But 1/3 of the patients will have persistence of the pulmonary hypertension, and we need to be aggressive on treat them with specific vasodilators. But of course, we have a big PH center in our department, and we are open, of course, to evaluate any patient with suspicion of pulmonary hypertension in a cancer context.
Thank you. I think that there are a question of in the CT. If you like, you are expert in CT. There are some other differences about the thromboembolism chronic pulmonar and these situations, the PTTM.
Mm-hmm. It's a very, very a good question. Sometimes and normally there's no specific findings on CT to diagnose the PTTM, the pulmonary tumor microthrombotic angiopathy. There is sometimes tree and bud pattern or some consolidations, but PTTM do not have a specific pattern on CT, a specific radiological pattern. Instead of the CTEF, chronic pulmonary hypertension, have some specific findings on CT, because we can have webs. There is strains of fibrothrombotic tissue on the distal or proximal parts of the arteries. But regarding the two conditions, CTEF or PTTM, there's no specific findings to diagnose one pathology instead of the other.
Before Miguel Menezes have a question, but in the resonance, the magnetic resonance, there are some paper in this. What do you think? If the magnetic resonance, the thorax magnetic resonance, what is the advantage or no in the future in this diagnosis?
So, depending on the type of pulmonary hypertension, the specific phenotype, if there is a pre-capillary or a post-capillary pulmonary hypertension, of course there is different findings on CMR. But in the cancer context, there's no specific findings on CMR that can help us to a specific diagnosis, because group 1, group 3, and group 4 of PH have the same phenotypic findings on CMR. In group 2 pulmonary hypertension, there is a pulmonary hypertension condition to the left heart disease, and of course with CMR we will diagnose the specific left heart disease that is causing the PAA, the pulmonary hypertension. But CMR has a role as a prognostic indicator, because there are several prognostic parameters that we can evaluate on CMR, and we can make a better prognostic certification of patients with CMR, for sure.
Thank you. Miguel, have a question.
Thank you, Dr. Lozada. Hi, Rui. Congrats on a wonderful presentation once again.
Thank you.
On this challenging topic. So I have a couple questions for you. One of them is regarding your clinical perception, and the other one is regarding on how you proceed. So because we've had for a couple of years now trials documenting the significant reduction on the rates of venous thrombosis and pulmonary thromboembolism with the use of DOACs, have you experienced a change in the kinds of patients that show up at the clinic, especially cancer patients? Do you feel that oncologists are using that, or on the contrary, do you feel that nothing has changed and it's still quite residual? And the second question is, because these cancer patients can sometimes have lots of long-term catheters and sometimes access difficulties, the threshold for progressing to right heart catheterization, do you change it on a cancer patient, or do you still apply the same principles of performing right heart catheterization as much as possible?
Okay, thank you very much for your questions, Miguel. Regarding the first one, of course, it's more and more frequent the use of NOACs, and in the field of pulmonary hypertension due to chronic thromboembolism, we know we don't have yet sufficient data to conclude, because we use NOACs, or we use warfarin, especially to prevent the recurrence of embolism in those kind of patients. And we know if the patient have antiphospholipid syndrome, we should not use them. It's the only reason to not use the NOAC in those kind of patients. But there's no evidence for, at the moment, that the use of NOACs will prevent the start of a chronic thromboembolic pulmonary hypertension phenomenon. We don't have yet robust data to say that. But of course, we need to follow the guidelines for the acute pulmonary embolism. But in patients with cancer, I think we don't have evidence to demonstrate the superiority of one group of drugs regarding the other to prevent the CTEPH condition. Regarding the second questions, you asked me about these patients have several catheter, can have prosthetic material, right, Miguel?
Yeah, I asked whether you proceed to right heart catheterization exactly as in the general population, whether you try to restrict the use of right heart catheterization in cancer patients and be as less invasive as possible.
Of course, we try to be the less invasive possible, especially in a patient with cancer. But of course, we need to stratify the situation very deeply at the beginning, because if we think that the patient have some kinds of risk factor to have an intrinsic precapillary vessel involvement, like in a patient that is taking a tyrosine kinase inhibitor, or a patient with a lot of status of lot of radiation, thoracic irradiation, or patients that took in the past alkylating agents, that is a risk factor for PVOD. In those conditions, of course, the threshold to make a right heart cath is much lesser, because we know that in cancer context, the other causes for pulmonary hypertension that are more frequent, there is secondary to left heart disease or to chronic pulmonary conditions. In those situations, if you have significant pulmonary involvement with an echocardiogram that show pulmonary hypertension, but with not the right ventricular phenotype, without significant dilatation of right cavities, we can establish a relationship between the clinic and between the echo and between the CT findings. And in those cases, we do not proceed with the right heart cath. Of course, if there is a suspicion of group 1 pulmonary hypertension or group 4 chronic pulmonary CTEPH, chronic thromboembolic pulmonary hypertension, for sure in those patients, we proceed with right heart cath to better stratify the situation and then to offer the specific therapies.
Thank you.
Thank you, Rui. I think that we are in time, and thank you for this section. For me, it's a beautiful section, and it's very complete to present the time. Thank you, Rui.
Thank you very much.
Good afternoon, everyone. So let's move on to the next speaker. It's a great pleasure and honor to present Dr. Ana Abreu. Dr. Ana Abreu is a senior cardiologist and she's the coordinator of the Master Degree in Cardiovascular Rehabilitation and professor at the Faculty of Medicine of the University of Lisbon. She's also the coordinator of the Cardiovascular Rehabilitation Program of the of CHULN, FMUL and CRECUL, and group leader of the Cardiovascular Exercise and Rehabilitation Union. Dr. Ana Abreu is one of the most recognized cardiologists in cardiac rehabilitation area, not just in Portugal, but in worldwide. So her lecture today is about a very interesting topic regarding exercise in cancer. Can it mitigate cardiotoxicity? Dr. Ana Abreu, the floor is yours.
Thank you very much. Thank you for the very nice and kind presentation. It's a pleasure to be at the 4th postgraduate update course in cardio-oncology of the Faculty of Medicine of Lisbon. I would like to thank the kind invitation of Professor Manuela Fiuza. So the topic of today is exercise in cancer. Can it mitigate cardiotoxicity? Cardio-oncology predominantly focuses on the detection and management of cancer treatment-induced cardiac dysfunction, which predisposes to heart failure and coronary artery disease. We know that cardiovascular disease has a lot in common with oncologic disease. We have a big interaction regarding common risk factors, underlying common pathophysiological mechanisms, cardiovascular complications due to cancer and cancer therapy, and cardiotoxicity, cancer treatments with left ventricular dysfunction, heart failure, and mortality. So cardiotoxicity is really a big issue. We know that therapeutic options who led to improvement in prognosis of cancer, namely in breast cancer, in the recent years, carry short and long-term side effects, including vascular endothelial dysfunction and cardiovascular toxicity. Cardiotoxicity is common to anthracyclines and chest radiation, but may occur less frequently with new biological therapies like trastuzumab. It can provoke left ventricular dysfunction and consequently heart failure, decreased quality in life, and survival independently of cancer-related prognosis. It is important to know that regarding cardiotoxicity, we have type 1, by direct myocytes toxicity with cellular death and possible impairment of respiratory mechanisms with permanent left ventricular dysfunction, that is the case of anthracyclines, and cardiotoxicity type 2 with reversible dysfunction, and that happens with biological therapy like trastuzumab. So, the definition for cardiotoxicity regarding guidelines of the American Society of Echocardiography and European Association of Cardiovascular Imaging are the decrease in left ventricular ejection fraction superior to 10% to a value inferior to 53%. We know that anthracycline cardiotoxicity is really a continuous and dose-dependent phenomenon. So we start by the acute myocardial damage translated by the elevations of biomarkers including entropy. Then it follows the impairment of left ventricular global longitudinal strain, GLS, and finally, in the end, we have the progressive decline in left ventricular ejection fraction, which can conduct to heart failure and death. Left ventricular global longitudinal strain is assessed by speckle tracking echocardiography and is an established marker for early left ventricular systolic function with a good reproducibility. It is an established measure to assess cardiotoxicity of anthracycline-based therapy in cancer. This table, published in a state-of-the-art of circulation of the American Heart Association, tell us patients at high risk for cardiac dysfunction regarding chemotherapy or radiotherapy. So what you know from here is that high dose of anthracyclines, high dose of radiotherapy, combination of lower dose of anthracyclines with other drugs, and the use of anthracyclines or biological chemotherapy in patients who are old, who have already cardiac dysfunction, or who have more than 2 risk factors for cardiac disease. All of these will put the patients at high risk for cardiac dysfunction. Survival and cure rates from early breast cancer have drastically increased. And now a major concern is cancer therapy long-term consequences on the heart. So in a study with more than 60,000 women diagnosed with breast cancer, cancer was the cumulative primary cause of death in the first 10 years after diagnosis. But after the 10 years, cardiovascular disease became the cumulative primary cause of death. In another study, at 7 years of follow-up, breast cancer survivors had the hazard ratio for cardiovascular disease of 1.8 compared to a normal population. And finally, a Swedish study found that women with breast cancer more often died from heart failure than women without cancer. So, exercise as cancer adjuvant. Will it be effective in prevention? So, we know exercise is effective in prevention in cardiovascular disease. But now the concept of exercise is medicine has become well established in exercise oncology research. Exercise therapy is considered safe, well-tolerated adjunct therapy to cancer patients. But, and there is a but, is exercise effectively regarding avoiding or decreasing cardiotoxicity? And this is the big question. Beneficial effects of physical exercise in cancer patients undergoing oncological treatment are well described in this revision of Flavio D'Ascensi of the Journal of Preventive Cardiology. We know that pathophysiological mechanisms are responsible for the benefits of exercise, and also these benefits are reviewed in the same paper, including the increased expression of antioxidant enzymes, the increase of functioning metabolic pathways, of increased proliferation and hypertrophy of myocardiomyocytes, and even white blood cells mobilization. So, in the same paper, systematic reviews and meta-analysis reveal that exercise training after chemo has beneficial effects on several parameters: cardiac respiratory function, body composition, muscular strength, pain and fatigue, quality of life, depressive symptoms, and survival. Exercise therapy. What is the role in cardiovascular toxicity? We know that research in exercise for cancer is primarily aiming cardiorespiratory function. We know also that poor cardiorespiratory function associates with higher prevalence of acute and chronic treatment-related toxicities, symptom burden, fatigue, risk of all-cause and of cancer-specific mortality in cancer patients. But regarding cardiotoxicity, what we know is that the knowledge on efficacy and mechanisms of exercise to prevent or mitigate cardiovascular toxicity after cancer diagnosis are limited. We only have small observational studies. Randomized controlled trials with cancer patients, large samples, are needed to evaluate the potential effect of specific tailored exercise programs on early left ventricular dysfunction due to cardiotoxicity. This is a very interesting randomized controlled trial performed by our colleagues from Hospital Villanova de Gaia, and it respects early exercise training in breast cancer treated by anthracyclines. And we know here that the primary aim is to ascertain whether a structured exercise program mitigates anthracycline-related chemotherapy measured by change in the levels of circulating biomarkers and cardiac dysfunction endpoints, left ventricular GLS, and ejection fraction. Another interesting randomized controlled trial is early exercise training in breast cancer and lymphoma treated by anthracyclines, called CAPRICE. This is an international study from University of Bern. Our center had the privilege to be invited to collaborate in this study, and the primary outcome measure is also, as in the previous trial, left ventricular global longitudinal strain. So, exercise programs in breast cancer, what do we know? We know that moderate to high intensity exercise training under supervision is safe adjunct therapy in breast cancer during chemo treatment. Evidence suggests that isocaloric programs, high-intensity interval training or moderate-intensity continuous training have similar improvements on peak VO2, peak work capacity, flow-mediated dilation, some cardiovascular risk factors, and quality of life. HIIT is more efficient than moderate intensity continuous training since there is lower energy cost and training duration for equal improvements in peak VO2. Previous studies indicated HIIT can reduce training adherence, whereas the increase in session duration or frequency are not associated with adherence reduction. Nevertheless, we must not forget that the results of the studies are always dependent on the patient samples and on individual characteristics like age, physical activity, habits, and motivation. Exercise in cancer, what about the timing during or after chemotherapy? Most clinical evidence on exercise regards implementing exercise program after conclusion of adjuvant chemo. Only few studies have been conducted using exercise during adjuvant chemotherapy. And the reason is easy. It was thought that exercise could aggravate the deleterious effects of anthracyclines on the myocardium. However, animal studies were encouraging, showing that exercise was, on the contrary, cardioprotective. And also in humans, exercise during chemo was shown to be safe, well tolerated, and effective in alleviating chemotherapy-induced reduction in exercise capacity, muscle mass, and strength, as well as improving fatigue. Now, exercise in oncology needs precision. What does this mean? It means that one size does not fit all, So we need to be precise, targeting the type, dose, and schedule of the exercise program according to individual and different groups of patients. Cardio-oncology rehabilitation to manage cardiovascular outcomes in cancer patients and survivors was a topic which was a motive of a scientific statement from the American Heart Association 2 years ago. And in this document, all the benefits of exercise and of a whole core program were shown. Of course, core components are more than exercise training in a core program. And we have, besides the exercise training, the assessment of the patient, the risk factors control, the nutrition, psychological and physical counseling, and follow-up, of course. And in the same paper, there is the answer for this question. Will core program result in less cardiotoxicity? And the answer is research is needed to demonstrate a reduction in cardiac dysfunction among patients with cancer enrolled in core programs. Because, as we know, most studies were performed with exercise training not included in core programs. So we cannot take the same conclusions from those complete programs regarding those only with exercise training. Looking at those breast cancer patients and lymphoma patients who undertake anthracycline-based therapy, what exercise protocol should we propose? Exercise training should be inserted as a component of CORE, a multi-component program. Exercise should start as early as possible, if possible, even before chemotherapy starts as prehabilitation, but if not, at least at the same time. A combined protocol with aerobic and resistance training, individually constructed, targeting the volume and energy expenditure in a patient's preferred modality instead of rigid model, should be used in order to promote adherence. So, we propose to target an early and tailored program promoting adherence in the type of program and inserting the exercise training in a multi-component core program. So while waiting for the results of the ongoing trials regarding the potential exercise benefits in cardiotoxicity, I would say that we should advise our cancer patients without contraindications to continue exercising and maintaining physical activity, because a workout a day keeps cancer away. And this is a sentence that many of these patients who already perform exercise training will understand very well. So thank you very much for your attention, and I remain at your disposal for any questions. Thank you again.
Thank you for the excellent presentation. The discussion and questions are now open. Any questions from the audience regarding this presentation? I can start with one while you are thinking. So I have a question regarding the specifications. So what specifications should we be concerned when we are prescribing exercise in cancer patients?
We need to prescribe the program according to the intensity that we want to achieve. But in these patients, we need to pay attention to two main important things. One, it is adherence. we know that these patients might fail in adherence because of feeling too much fatigue while they are doing cardiotherapy. For on one hand, they would like to do the program if they are really motivated and they understand it can be good for them. But at the same time, we really need to adapt our program, the type of exercise will be performed in order that they can be glad to attend and they adhere the program. And at the same time, it must not be rigid, not only regarding of the modality or type of exercise we are performing, but it might also need to be adapted in those moments where they are feeling more tired or some other symptoms. So we need to be always adjusting. Each day they are performing exercise, they need some kind of evaluation to do some questions and to understand exactly what are they able to do exactly on that day. I think this is really the most important.
Okay, and even after any surgery, for example, for breast cancer patients, there are other limitations on the upper limbs, for example?
Yes, of course. These trials that are going on are with patients with chemotherapy, not after surgery. But after surgery, it is possible and desirable, but it should be, we should wait at least 4 weeks, and we should be careful, of course, with mobilization and resistance training in superior limbs, of course.
Okay, thank you. So we have a question here from Nelson. His microphone is not working. So what are the main contraindications to start rehabilitation in this kind of patients?
One of the contraindications is exactly what we talked, that is immediately after surgery, we cannot do it, of course. And then we are talking about patients without metastases. Those trials are performed in patients without metastases. So we have to be much more careful if we think in more severe cases. And it might be not absolute contraindications, but if you have a complication of cancer, even a cardiovascular complication like thromboembolism or something, you need to be aware of, and we need to see what is the exact time where you can perform the program, the exercise program, because the core program, the other components, can always be performed.
Okay, thank you. Any other questions?
I have a question. But first of all, I would like to congratulate you, Anna, for this lecture. It's such a recent issue. We know many about it. But I have a question. Do you think that exercise, in addition to the known effects in quality of life and cardiovascular risk, might make the tumor more sensitive to anti-cancer therapies?
That's what I would like to know exactly. Thank you very much, Manuela. That is very interesting, because that is one of the best questions we have now. If we could modulate with exercise, because we can activate some pathways and we can act with exercise on the expression of certain genes. That's what we think, at least. And if we can prove that in patients, in human patients, and with large number of patients, that would be really fantastic. What we know now is the results on quality of life, on fitness, on symptoms, that we know that exercise is good. But if we could demonstrate that it really influences the way of response of the patients to chemotherapy and the pathways that are used for this benefit, that would really be great. And I believe that this trial from the University of Bern can help. And after these trials, we need to have more studies regarding mechanisms, not only regarding the improvement of outcomes, but also regarding the mechanisms by which exercise can be changing. What I think also is the same as for mental health patients. We cannot separate exactly the effect of exercise besides other effects, like the close coaching of the patients, the potential psychological effects of group exercising, and the effect of being more closely supervised when they are inside exercise programs. That might also make a big difference and cannot be separated from the pure effect of exercise.
Okay, thank you.
Thank you.
If I may,
Go ahead.
I have another question is, in your opinion, what could be the most important factors to prescribing the training? The stage, the type of cancer, the presence of metastasis, for instance, the patient cardiovascular risk, for instance, also. What do you think, in your opinion?
I think the stage is very important, of course. What I said a moment ago regarding the timing of beginning, I think can make all the difference. And that's what you were talking before regarding the influence exercise might have on the way the patient responds to treatment. The early we start, the early we can influence these effects. If we start in cancer survivors, like most studies, I think we are missing some opportunities. So one of the things, it would be the stage of the cancer, the timing of intervention. Another thing that, like you said, the pre-existence of cardiovascular disease, which might be very important because exercise can act in both. Like in the first slide I showed, there is a large interaction between cardiovascular disease and oncologic disease. So we are acting in these patients in both systems, in both diseases. And I think age is also an important factor to be aware of. And even the type of exercise needs to be adapted to age, not really the chronological age, but biological age. And that is also important. And we also know, and there are studies regarding the fact that exercise also can have an effect on the biological age. So I would look at these points as very important when we are looking at a cancer patient for prescribing an exercise program inserted in a core program.
Okay, thank you. I think we have time for the last question. Andrea, go ahead.
Hello. Good morning to all. I think it was a very nice presentation, and I think it's a very interesting topic. Sim? Okay. And I would like to ask you something. Do you think that this time, during the COVID pandemic, this was a challenge for you on the rehabilitation? And did you have to reinvent yourself? And what do you think that is can be an advantage, this online training, to reach more people? What do you think about that?
You're talking about cardiac rehabilitation in general, right? Or yeah, okay. Thank you for the question. Yes, this was a good opportunity to reinvent our program, because we had to transform it in a digital format. What we are doing and what we have been doing this time is to try to evaluate patients in presence, in physical presence, because that is really important, and then prescribing a program to be performed at home. If you ask me if this has good results, it has, because we have already analyzed our 100 first patients who undertake this program with Professor Rita Pinto, who is here with me, and she knows a lot about these results. We are trained to publish a paper regarding those outcomes that were really good. But if you ask me, what do I think? Should we transform everything now from physical presence to digitally? The Zoom exercise group sessions that are digitally supervised and monitored, and educational sessions that are already provided by computer to our patients, and they like it. Most of them like it and have the means, because not all patients have these digital means. But if you ask me, would you change everything? I would respond, no, because I think that the best in cardiac rehabilitation is to adapt. We want patients to be there. We want to get the patient inside the program. So we need to understand those patients who cannot do presentially or prefer not doing it presentially. And for those patients, I think digital way is just fine. And we have also to understand that there are other patients that really take advantage of doing it presentially, who live near, do not live very far away, who are older, many of them, and who get more advantage of having presential programs. So what we have now is the possibility to have both modalities, and we have also created a hybrid program, which allows patients to do at regular times exercise inside the institution, and meanwhile they can have most sessions at home. So we have to be imaginative to be able to grab people inside the program. So also for cardio-oncology, I think that is the way to go. Maybe these people need more a presential, a physical presence, at least in the beginning. I think we can give them more. But if not possible, if they live far away, we can do it online, and I think that can be good for them.
Okay, thank you. I think we have one last question from Elio, and then we close the session. Elio, go ahead.
Thank you so much. Congrats, Professor, for your excellent presentation. The question is, we need to consider some big red flags when we prescribe or recommend the exercise to that patients, that cardiovascular, but cardio-oncologist patients. Can you tell us some red flags we need to consider for these patients?
When you are talking about red flags, you are talking about contraindications, limits?
Yes, contraindications, like these contraindications, or if the patient make some exercise and we need to stop the exercise.
Okay, criteria for interruption. Yeah. Yes. Okay. the oncologic patients can have cardiovascular disease already or not. And we know that because they are evaluated before. And we do a stratification of cardiovascular risk in all the patients. We know we have low cardiovascular risk for exercise, intermediate, or high risk. So the monitoring and the supervision should be looking at this risk, should be more intense in the high risk and are less intense in the others. So what we do is we educate the patient in order that if the patient feels chest pain, dyspnea, lightheadedness, any of these symptoms, they should tell us and they should stop, and we should try to understand what is happening. At the same time, they need to be monitored in the beginning by ECG. The cardiovascular disease or the high risks, they are certainly by ECG monitored, and we need to have monitorization of heart rate and of blood pressure. And if we have problems like with a hypotensive response to exercise or a hypertensive response to exercise or a bradycardia, arrhythmia, or tachycardia or fibrillation, for instance, tachyarrhythmia, we need to stop immediately, and that patient needs evaluation. And we should not start another session again before the patient is stable, of course. Another thing very important is if there is acute event, like for instance, if a patient has fever or if the patient got flu, cough, pain in the muscles or something, we need to understand if he has some intercurrence like a viral infection or so. And in that case, patients cannot perform exercise sessions, of course. Thank you for your question. Very good.
Thank you.
Okay, so I want to thank you all the participants. Last question?
Last
of the last, okay.
Last of the last.
Go ahead.
Afterwards, I have an announcement to make. But do you think these cancer patients should exercise together with those cardiology patients or have a separate training?
I think they should have a separate training. I think even the cardiovascular patients, I would like to have separate trainings because you have specificities of the training and of the psychological and physical aspects of these patients. So these patients need to be together. They need to have the same problem, the same underlying problem. And usually our groups of rehabilitation, they share experiences. And it is important, they are feeling, they are fighting the same problem at the same time and with the same means. And this is part of the therapy. Like I told you before, it's not only physical exercise, it's all the rest that exercise involves that is important. So even in cardiovascular patients, I like to have heart failure groups, coronary groups, ladies groups. It is important because women also have different tastes and we can create different programs for them. So, and these patients, oncologic patients, also can have the relaxation activities like yoga and other kinds of specific programs that are good for them. So thank you very much. I think that is a very good question, Professor Manuel, and thank you for inviting for this session, which I think it's really, really very important. Thank you.
Thank you. Couldn't be more clear.
Okay, so let's move on to the next conference. Thank you so much to all to be here on this conference. Thank you, Dr. Ana Abreu, and thank you for the invitation for being here. Thank you.
Thank you. So I have an announcement to make, and which is the following. The Professor Ludmila is delayed in a meeting at Health Ministry. So she only is able to do the lecture in the afternoon period, perhaps at 2 hours, 2 o'clock. So we make the lunch break now, and we are back at 2 o'clock. Thank you.